So my name is Manal Abdelrahim. I'm a second-year medical student, and today I'm going to be doing the CVP OSPE crash course alongside my colleague. Muhammad, are you here? Muhammad. Okay, so alongside my colleague Muhammad Arshad, you're muted by the way, we can't hear you if you're talking to us.
Sorry, guys. Can you guys hear me now?
Yeah, we can hear you.
Okay, good. So, like Manal said, this is going to be today's CVP 112 OSPE. Inshallah, we're going to cover pretty much everything that you guys are going to need to know. What I will say, however, before we get in, is that you should never be using PAL as your primary source of study. This should only be for revising, or like if you haven't had a look yet and you want to get a preliminary overview of the content. Okay. So make sure that this isn't the only thing that you do. Make sure that you go back to the lab guides and the transcriptions, because that's what we personally use to make this OSPE. Okay. So I'm going to be starting off with the cardio labs, and then Manal will be taking it from there with the pulmo lab. So let's just get straight into it, because to be honest, we have a lot of content to get through. Okay, so the way that I'm going to be working through it is I'm going to be starting off with the dry lab, then the wet lab, then the histo labs, and then at the very end I'll be covering the cardio physio lab that you guys did in week 2. Okay, so getting straight into it, the first thing that we looked at in the dry lab is the thoracic skeleton. Okay, and this just consists of the sternum, 12 pairs of ribs, and the thoracic vertebrae. Okay, and the most important thing, I guess, that you need to know here, other than the bones, is that this is the superior thoracic aperture, aka the thoracic outlet, and you have the diaphragm at the bottom and the inferior thoracic aperture or outlet. Okay, so the first, and honestly, to be honest, maybe the highest yield bone that we need to be looking at is the sternum. So what is the sternum? Where is it located? It's going to be located anteriorly in the chest wall. And what is the structure of the sternum exactly? So there's a couple of different things that we need to look at, a couple of different key features. The first and most important thing that we need to look at for the sternum is the sternal angle, okay? It's also, it's referred to by a couple of different names. You also hear sternal angle, manubrial sternal angle, or sternal angle of Lewis. And something that's super important to know, and this is very, very high yield, if it doesn't come in the OSPE or SAQ, it's probably going to come in the MCQs, it's that it's located at the T4 to T5 level. So that's thoracic vertebrae 4/5, it's in between there. And it's the junction between the manubrium, which is this area of the sternum, and the body of the sternum, okay? And why is it so important? Well, the sternal angle marks the attachment of the second costal cartilage, or the rib, and so we can feel the sternal angle, actually. It's palpable. So we know that this is where the second costal cartilage or rib is, and using that information, we can then number the different number of ribs and intercostal spaces. And that's relevant to a number of different things, right? So we can tell where the apex of the heart is, for example, and it's relevant for a bunch of different clinical procedures. For example, the insertion of a chest tube or a needle insertion during pericardial which I'm sure you guys have covered. It's basically when you have like an inflammation, like you have excess fluid buildup in the pericardial cavity. Some other important things, you have the clavicular notch, which is for the attachment of the clavicle bone to the sternum, and it's the sternoclavicular joint that attaches them together. Then you have the jugular notch for the jugular vein, and the xiphoid process, it doesn't really attach to anything. By the way, guys, the bold here just means like it's high yield, but you guys should know everything on the slide. And the same thing goes for the star, right? So if you don't see a slide, if you see a slide without a star, you should still know it. Now we're going to move on to the ribs. So the most important thing that we need to know here are the different classifications of the ribs. And let's just get straight into that. So we have classifications through the features of the ribs. We have classifications with respect to their relation to the sternum. And then we have classifications with respect to their articulation. So first of all, the features of the ribs. Ribs 3 through 9 are referred to as typical ribs, and that's because they all share a very similar shape, and they share the exact same shape and the exact same features. And then you have the atypical ribs, which are the 1st, 2nd, 10th, 11th, and 12th. The only really important one from your guys' lab, according to transcriptions, is the first atypical rib. And then you have the relation to the sternum. So ribs 1 through 7 are the true ribs, and ribs 8 through 12 are the false ribs. So what does that actually mean? Well, if we zoom in here, we can see that ribs 1 through 7 are actually going to be directly attaching to the sternum, whereas these ribs down here, they don't attach directly to the sternum, right? They're going to be attaching to something else. And that's where the classification through the articulation of the rib comes into play. So the vertebrosternal, aka the 1st through 7th ribs, are the true ribs. They're going to be attaching directly to the sternum, and they also go back and attach to the vertebrae, okay? That's why they're called vertebrosternal. Then you have the vertebrochondral, which are the 8th through the 10th, okay? And what these do is that they articulate with the vertebrae, but they don't go and articulate directly with the sternum, right? Instead, they're going to be articulating with the costal cartilage of the rib above them. And then you have the just vertebral or floating ribs, which are the 11th and 12th ones. And as you can see, these ones are going here and articulating with this costal cartilage, but these ones aren't even doing that. They're just floating, right? So they're only articulating with the vertebrae, and hence they're just called vertebral ribs. Okay, so now let's get into the features of the typical ribs, which are the 3rd through 9th ribs. So working, posteriorly towards the anterior, we're going to start off with the articular facets. So the typical ribs, they have an articular facet for both the vertebrae that's numerically above to them and the vertebrae that numerically corresponds like with that number of ribs. So what do I mean by that, right? Let's say that this is rib number 3. This articular facet would go and articulate with the second vertebrae, and this articular facet would go and articulate with the corresponding number, which is number 3, right? So it articulate with the third vertebrae. Then you have the tubercle, which again is just going to be articulating with the vertebrae, and it's going to articulate with the numerically corresponding vertebrae. Then moving over a little bit, we have the costal groove, okay? The costal groove is, it's inferior and it's on the internal surface, and it's important because it contains space for the intercostal vein, artery, and nerve. Now, this is super, super, super high yield, and there's a good chance that this is going to come in your OSPE, so please focus. But basically, what you need to know is that the most common site for fractures in the rib is at the angle or the costal angle. So again, this is just to quickly, summarize what I just said. So the most common site of fracture is going to be the costal angle, which is over here. It's right after this area with the articular facets, the head and the neck and the tubercle, but it's before the costal groove. And then you have the costal groove, which has the intercostal van, which is vein, artery, and nerve. And then again, you should just know that the tubercle articulates with the same number of vertebrae, and then the two heads. One of them is going to be articulating with the same number of vertebrae, and one from the number above. Okay, so this is what an atypical rib looks like. There's also some other atypical ribs, but this is just the first one. And this is the one that Dr. Atif talked about in your guys' lecture. So as you can see here, it's a lot flatter and broader than, the typical rib. And Saraha, you can't really mistake these two. Like they look very, very different. It only has one head. Again, this is the first rib. So it's just going to be articulating with the first vertebrae alone. There's no vertebrae above the first vertebrae. So you don't need two heads. And then it has this scalene tubercle. Now, what's the point of the scalene tubercle? It's a point of insertion for the anterior scalene muscle. You guys should probably know that. I don't know how high yield it is, but you should still know that. And then you have grooves here for the subclavian vein and artery. So the only really important thing that you need to know here is that the vein is going to be more anterior, and then this groove that's more posterior is going to be for the artery. And just something to know in general is that in the front, like this anterior area here as well, this is where you're going to have the articulation with the costal cartilage. So that's where you're going to be articulating with the sternum. Okay, so we finished the sternum, we finished the ribs. Now we need to talk about the thoracic vertebrae. So let's work our way from posterior to anterior again. So posteriorly, you're going to have this, first of all, you're going to have this spinous process that's going to be sticking out. And then you're going to have these facets. And these facets are just for the articulation with the tubercle of the rib that we previously spoke about. These transverse processes as well. This is like for the articulation with the tubercle of the rib. You have the pedicle, which is just going to connect this vertebral body to this, like spinous process that's sticking outwards. And then you have the vertebral foramen, right? This is very important because this is where you're going to be holding the spinal cord itself. And also worth noting is that you have inferior and superior articular processes. So if you go over here, this is the inferior articular process. I believe this is the superior articular process. These just exist so you can articulate one vertebrae with the other vertebrae that's both above and below it, right? Because again, it's a cord. So you have like vertebrae, and you need to articulate between them. Okay, so now we're going to be talking about the mediastinum. I'm going to be covering this like pretty briefly because, to be honest, it's more so related to your guys' lectures, but it's just important for orienting ourselves for this next upcoming lab. So what is the mediastinum? It's just the area between the two pleural sacs within the thoracic cavity. And you need to know that the divisions of the mediastinum begin with the sternal angle, which is what's going to separate superior and inferior mediastinum. And then the other important thing that you need to know for this lab is that the heart with its pericardium is located in the middle mediastinum. And you also need to know the difference between location and position. Your guys' lab TA talked about this in the transcription. The heart is located within the thoracic cavity, but it's positioned within the mediastinum itself. Okay, so I need you guys to focus here with me. We're going to be going over the basics of the heart. I'll try to go over this quickly because I'm sure you guys already know this for the most part. But the basic structure of the heart is that it has 4 chambers. There's 2 atria and 2 ventricles. And when you're looking at the heart, to make sure that you're looking at it with the proper orientation, you can use a specific acronym called CAT. So CAT means that from left to right, or well, technically from the patient's right to left, but from your left to right, you should be looking at the cava, which in this case refers to the superior vena cava, the aorta, and then the pulmonary trunk, okay? So that's the order that you should be seeing them in. Next up, we'll talk about the flow of the blood within the heart. So blood, which is deoxygenated, comes through the vena cava, through the right atrium, through the right ventricle, out through the pulmonary artery, and then it goes to the lungs where it becomes oxygenated. So I highlighted this in blue. I need to know that this part is called the pulmonary circulation. Then you're going to have the blood come back through the pulmonary vein and into the left atrium, into the left ventricle, and through the aorta to the rest of the body. And this is called the systemic circulation. And the important part to know is that this blood is all oxygenated. Then you have a couple of different valves that you need to know. Valves just help control the flow of blood. So like they, help prevent regurgitation of the blood back into a chamber, and they help, prevent like prematurely letting blood through, right? So you don't want to prematurely let blood through from the atria to the ventricle, for example. So you have the tricuspid valve, which is between the right atrium and the right ventricle, and you have the mitral or bicuspid valve, which is between the left atrium and left ventricle. And you also have the aortic and pulmonary valves, which is between the left ventricle and the aorta and the right ventricle and the pulmonary trunk. Now, something super, super important, and like it's an absolute basic, it's an absolute must, is that you always have to orient yourself properly. And what do I mean by that? Well, you have to recognize that your left and your right are the opposite of what the patient's left and right is, right? So this is technically right for me when I'm looking at it, but this is the patient's left. Hence why we refer to this area as the left atrium, left ventricle, right atrium, right ventricle, even though this is technically on the left, but you're looking at it from the patient's perspective, not from your own perspective, okay? So now let's talk about the different layers of the heart. Starting with the outermost layer, you have the pericardium, which is basically just the protective sac around the heart. Now, the pericardium has a couple of different divisions. First of all, you have the fibrous pericardium, and this is just a rough, inelastic protective layer. Then you have the serous pericardium, and the serous pericardium is split into 3 divisions and 2 sort of layers. You have the parietal layer, which is more outwards, and you have the visceral layer of the serous epicardium, which is also known as the, you have the visceral layer of the pericardium, which is also known as the epicardium. And in between the 2 of them, you have the pericardial cavity. Now, something important to note is that the pericardial cavity is filled with pericardial fluid, and this fluid comes from the visceral pericardium, also known as the epicardium, which is going to secrete this fluid. It secretes this fluid through its mesothelium, which we'll talk about later on. And what is the point of this fluid here? Well, for one, it acts as a lubricant. Second of all, it's a shock absorber because, you're moving all the time and you might be like subjected to shocks. Like if you're like running, for example, right, your heart is going up and down. So it helps prevent shock and also helps prevent overstretching when the heart is being filled with blood. You don't want the heart to stretch out too much and potentially rupture. Okay, so now we have the second layer of the heart, which is the myocardium. And this is the muscular layer. And it's muscular that's responsible for the contractions that help the heart to pump the blood. And it's the thickest layer, as you guys can see here. And it has cardiomyocytes, which are specialized cardiac muscle cells. Now, something important to know is that it's thickest in the left ventricle. And you might ask yourself, why is that the case? It's thickest in the left ventricle because the left ventricle pumps out blood through the aorta to the entire body. So it has to be significantly thicker, as you guys can see here, because the right ventricle is just going to lungs, whereas the left ventricle is going to the entire body. So it needs a lot more force to do its job. And then you have the inner layer. This is the endocardium. It lines all of the chambers and valves of the heart, and it basically just ensures that you have smooth blood flow. Okay, so this is like very heavy in memorization, but I'm going to try to use a tool to make this a little bit easier for you guys. But you need to make sure that you memorize both the borders and the surfaces. This isn't necessarily the most OSPE heavy thing, but it can definitely come in the MCQs. So before we get into that, it's important to note that the heart isn't actually oriented like this. It's not sitting straight upwards. Can anybody unmute and actually tell me how the heart is meant to be oriented, or how it's like where it leans towards in the body? Anybody?
The apex is bent towards the left.
Yes, okay, that's correct. So like the heart is around 2/3 towards the left and 1/3 towards the right. And you guys can see that here, right? It's very heavy towards the left. Bear in mind that I'm talking about the patient's left, of course. So let's just get straight into the borders. So for the left border, you have the left ventricle. For the right border, you have the right ventricle. For the inferior border, you're going to have the right ventricle mainly and a small part of the left ventricle. This is around the apex area. And then for the superior border, you're going to have both atria plus these vessels. And then the other thing that you need to know is the various surfaces of the heart. So you have the sternocostal surface, which just refers to the anterior surface, which is the right atrium plus the right ventricle. Okay, you guys can see that the right ventricle is taking up pretty much all of the anterior view. And the posterior surface is the left atrium, and you have the right and left pulmonary surfaces. So the heart is surrounded on both sides by two lungs. So that's what this is referring to, right? So you have the right pulmonary surface, which is going to be the right atrium, and the left pulmonary surface, which is going to be the left ventricle. And then we typically like to think of the heart as a pyramid. And in that pyramid, the apex of the heart is the left ventricle, and the base of the heart is the left atrium. Now, to be completely honest with you guys, like this 2D picture doesn't do the heart and what I'm talking about any justice. So I found a 3D visualizer, and I hope that it'll be able to help you guys. So as you guys can see here, this is the regular orientation of the heart. We can see the cat, which is the cava, aorta, and the pulmonary trunk. And this is the sternocostal surface, right? So you can clearly see that this is like the bulk of this is being taken up by the right ventricle. And then if we move towards, if we do a 180 and we go to the posterior surface, you can see that this is mainly being taken up by the left atrium. Then if we look at it from below, you can see that both ventricles kind of take up this diaphragmatic surface, which is the inferior surface, which is both ventricles. So you can see that both ventricles, both right and left here, are taking up that. And then if we go back here, I want you to imagine that there's a lung over here and a lung over here. So if we're looking at the lung over here, you can see that's mostly the right atrium that's going to be taking up this right pulmonary border, or right pulmonary surface, sorry. And then if we think about the lung over here, it's mostly the left ventricle that's going to be taking up that. And if we want to visualize, the heart as a pyramid, as you can see, it's kind of like a pyramid like this. You can clearly see that the apex of this pyramid is with the left ventricle, and the base of this pyramid, like assuming that it's like this, the base would then be the left atrium. So I hope that 3D visualizer helps a bit more, because to be honest, like these 2D photos and these textbook images, they never really helped me personally. So yeah. Okay. Now we move on to the two sinuses that were talked about in your guys' lab, which are the transverse pericardial sinus and the oblique pericardial sinus. Now, to be honest, the more important sinus here is the transverse one. So what you need to know is that it's superior to the left atrium, so it's above the left atrium, but it's this kind of gap behind the aorta and the pulmonary trunk. And its clinical significance is that it gives, a surgeon who's about to perform a surgery access to these great blood vessels and allows them to clamp these vessels. And why would you want to clamp these vessels? It's mostly just to prevent like any excess bleeding during surgery. And then you have the oblique sinus. It's not necessarily as high, but you should definitely still know this. It's known as a dead end sinus, because if you felt it in the lab, when you put your hand there, and I think I have a picture here as well, when you put your hand there, it's a dead end, right? It doesn't go anywhere. Whereas this is like, it's not necessarily a dead end, because you can still like extend your finger all the way out through. It's a dead end sinus, and its most important function is that it allows the expansion of the left atrium. It's located behind the left atrium. So behind the left atrium, and it's behind the pulmonary veins and the inferior vena cava. Okay, and then these are just some pictures on a cadaver. So you can see the transverse sinus. We're gonna put our finger through like this gap over here, and you have the aorta and the pulmonary trunk, and the oblique sinus is just gonna be behind the left atrium. Okay, so now let's get into the three sulci. So sulci are pretty much just grooves that are present on the surface of the heart, and there are three of them that you need to know for your lab. And the most important thing about them is that they have veins and arteries that are supplying the heart itself running in them. So there isn't really much to say here. You have the anterior interventricular sulcus, which is just a groove that runs between both ventricles, and it's on the anterior surface of the heart. You also have the posterior interventricular surface, sulci, sorry, which is going to be running between, again, both ventricles, but on the posterior surface of the heart. And then you have the coronary or atrioventricular sulcus, and as you can probably tell by the name, it's between the atria and the ventricles, and it's on both the left and the right side. It's just showing one side here, but it's on both sides. And then your lab team, like very briefly talked about the phrenic nerve, and he kind of just wanted you guys to know that the phrenic nerve, which is over here, it runs lateral to the internal thoracic artery. That's all I could really find in the transcription. You guys definitely should be able to identify the phrenic nerve. I'm sure you guys have seen it on a cadaver before, and it could potentially come in the OSPE. Something that helped me personally identify it the most is that it runs like very close to the pericardium of the heart, as you guys can see here. Okay, so we're done with the dry and wet labs, and now we can just get straight into the histolab. So we previously spoke about the different layers of the heart, but this is what the actual histological slides of them look like. So first off, we have the epicardium, which again is just the visceral layer of the serous pericardium. And you can see that here you have the serous fluid. It's facing the serous fluid. This is the pericardial cavity. And the most important identifying feature, and this is very, very high yield for the OSPE, is the presence of these coronary vessels in adipose tissue. So these are like coronary vessels, and this white stuff here is the adipose tissue. And then something else that's important that they could ask you about, this layer of epithelium up here, this is all called mesothelium, and it's simple squamous, and it secretes serous fluid. And then this is a little bit less high yield, but you should definitely still know this. The right vessel over here, the right vessel, the larger one, it's the coronary artery. And this left vessel here, the smaller one, is the cardiac vein. And this is another histological slide of the epicardium. So as you guys can probably guess, this A here, this is referring to the mesothelium. And then E, this is the cardiac vein. D, this is the coronary artery. Bear in mind that the coronary artery is always going to be bigger. And 1, this is just the lumen of the pericardial cavity. So again, this is where the serous fluid is going to be. And you guys should also know that you guys should also be able to tell where the epicardium is ending and the myocardium is beginning. So like the epicardium is dominated by this white sort of adipose tissue, whereas the myocardium is dominated by this these pink cardiomyocytes, right? So you can see again here, this is all like very dark pink, and this is all white. So it helps distinguish the epicardium from the myocardium. Okay, now let's talk about the endocardium. So the most important identifying feature is the presence of Purkinje fibers. Now, what are Purkinje fibers? They basically just help conduct electrical signals in the heart. I'm sure you guys took that. But if we look over here, this is what the Purkinje fibers are specifically. And you guys should definitely know what these look like. And then you have the endothelium, which again, this is just going to be facing the blood. And again, it's just a simple squamous epithelium. And you should also know that these Purkinje fibers, which I was talking about here, they're present in the subendocardium. Now, it's also possible on the OSPE that they just ditch this kind of slide and just give you the subendocardium directly. And in this case, you should be able to identify the Purkinje fibers. Their identifying characteristics are that they're round, large, and pale. So you can clearly see here, very round, very large, and very pale. And they can be easily distinguished from the cardiomyocytes of the myocardium because these are significantly smaller and they're not as big. And make sure that you can distinguish, again, between the endocardium and the myocardium. Okay, so we spoke about the endocardium, we spoke about the epicardium. Now let's speak about the cardiomyocytes, which make up the myocardium. So they gave you 2 different slides in the lab slides, and those are the hematoxylin stained ones and the H&E stained ones. I don't necessarily think it's important to know, but you should just have it in the back of your mind that this is hematoxylin and this is H&E. So first of all, and this is extremely high yield, is you need to be able to identify where the intercalated discs are. So let's zoom in a little bit. This is an intercalated disc. This is an intercalated disc. There aren't any more on this. This is an intercalated disc. So how do we know that it's an intercalated disc? It's going to be horizontal. It's going to be very flat, first of all. It's going to be pretty thin, and it's going to be running horizontally, right? So you can see this is the nucleus, for example. This is running vertically, but these are all running horizontally, and they're very flat and thin. Something else that you need to be able to distinguish between is the nuclei of the smooth muscle cells. So first of all, they're located very centrally. They're called central nuclei. And this is what the nuclei of a smooth muscle cell would look like. And then this is what the nuclei of a fibroblast would look like. So you can clearly tell that like the nuclei of a smooth muscle cell, they're a bit bigger and a bit they're a bit wider as well. They're a bit thicker. Whereas the fibroblast is like a bit more thinner. Its nuclei is a little bit more thinner. Some other important things that you need to know, there's branching. That's what 2 is talking about, right? So you can see these branches here. And it's not really as clear here, but you can see some striations here as well. So cardiac muscle cells are striated. And then on the H&E stain, sorry, you can see this is clearly an intercalated disc. This is an intercalated disc. Again, it's horizontal, flat, and thin. And then these are the nuclei. So nuclei, nuclei, nuclei. And again, they're a bit bigger and a bit thicker as opposed to this B over here, which is referring to the fibroblast nuclei. Okay, so this is a histological slide of a mouse heart. To be honest, there isn't a whole lot of need for, you don't really actually need to memorize this at all because you can just like use your previous knowledge that we spoke about. So this is obviously the outermost layer. So this is the epicardium, this is the myocardium, this is the endocardium. Again, we're looking at endocardium because this is dealing with the blood over here. Myocardium, endocardium. This is obviously like epicardium because it's the outermost layer. This is the one, oh, sorry. This is the one thing that like you can't really tell if you don't know it, but this is a papillary muscle. And I'll be talking about the papillary muscles more in a bit, but you should know that this is the papillary muscle. And this is just the lumen of the left ventricle and the right ventricle. This has blood in it, right? That's why this is the endocardium. Something that you definitely should be able to do is you should be able to appreciate the thickness of the left ventricle here, which again, as we spoke about previously, is much, much thicker than its right ventricle counterpart because it has to pump blood to the entire body. Okay, so we're at checkpoint 1. We finished week 1 of the content. It's honestly, I don't think it was that much, so hopefully it was pretty easy for you guys. So I want you guys to unmute and let's try some practice questions together, okay? So first of all, I want somebody to unmute and identify what 1 and 5 here are. And then I didn't necessarily cover this, but it could potentially be asked. What is the purpose of the intercalated discs as shown here? If you guys could unmute, I would prefer that because I can't see the chat.
Hello.
Hello, I can hear you.
So number 5 is for the, number 5 is not cardiac muscle.
So what is it the nuclei of?
Fibroblasts. Yeah,
Yes.
Fibroblasts.
That's correct.
Because
So
it's
what does that
squashed. That's for the cardiac muscle.
Okay, good.
Myocardium.
And what is the purpose of these intercalated discs here?
It separates the 2 cardiac muscles from each other.
Okay, that's true, but there's like a
Gap
specific
junctions.
physiological purpose.
Gap junctions.
Could you repeat that?
Gap junctions.
Okay, yeah, that's true. So it's going to help to conduct the electricity between different cardiac muscle cells. So 1 is the central nuclei of the smooth muscle cell, 5 is the fibroblast nucleus. And then it's something called physiological syncytium. It allows the conduction of electrical signals and uniform contraction. So all of the cardiac muscle cells contract at once due to the intercalated disc. To be honest, it wasn't really touched upon in the slides, but I thought it was important to include this.
Could you describe what the intercalated disc do?
Okay, so basically, you have all of these different cardiac muscle cells that are joined together, right? And you want to conduct electrical signals between them. And you also want first of all, you want very rapid electrical conduction between them, right? Because you want, like, your heart is contracting very rapidly, right? It needs to be able to respond to stimulus rapidly. So it's called a gap junction, which your colleague mentions. It's a gap junction, and it helps conduct electricity between the different cells, and it also helps for uniform contraction. And that's something called physiological syncytium. The uniform helps with the uniform contraction. Okay.
Okay, thank you.
No problem. Okay, can somebody else unmute and answer this question? What is the most common site of fracture, and what rib would be between T4 and T5? So T4 vertebrae and T5 vertebrae.
Can I?
Yeah, go ahead.
The most common site for rib fractures is the angle, the costal angle.
Yes, that's
And
correct.
between T4 and T5, it would be rib number 5.
That is correct. Both of those are correct. Good job. By the way, if you guys have any questions, once we finish these practice questions, I'll stop for a moment. And if you guys have any questions about anything that I covered like beforehand, just ask me, okay? So this is the next question. Can somebody else please unmute and answer which pericardial sinus is this probe going through? What structures are anterior to it? And what is the clinical significance of it? Anybody?
Can I do it?
Yeah, go ahead.
So this is the transverse sinus.
Mm-hmm.
Anterior to it is the ascending aorta and the pulmonary trunk.
Yep.
The clinical significance is it allows the surgeons to put clamps on the great vessels through it. So
Perfect.
yeah,
Yep,
through
perfect.
insert. Thank you.
I think this is our last practice question. So, okay, to be honest, it's kind of obvious because I didn't really cover it up, but which one is the epicardium, which one is the endocardium, and why? What are distinguishing features that tell you which one is which?
Can I?
Go ahead, I guess.
Okay, the one on the left is the epicardium. The distinguishing features is the coronary vessel and vein
Yep.
and the
Perfect.
adipose tissue. Okay, and the one on the right is the endocardium.
Yep.
The identification is Purkinje fibers
Okay. And where are the Purkinje fibers located?
in the subendocardium.
Perfect. Okay, so now we finished week 1, we finished the practice questions. Let's move on to week 2. So starting off with the coronary sulcus, we previously spoke about this. It's also known as the atrioventricular sulcus, and it runs between the atrium and the ventricle, okay? And what I want you guys to do with this image specifically is I want you to appreciate the coronary artery that's running through the sulcus, okay? Because as we said, the purpose of the sulci, or the significance of the sulci, is that they have veins and arteries that are supporting the heart itself running through them. So here we can clearly see an artery, the right coronary artery, running through the right coronary sulcus, okay? And there's also a left coronary artery that runs through the left coronary sulcus, because like I said, there's a sulcus between both atrium and ventricles. Okay, so let's start off with the right coronary artery. As we previously said, it's going to be running through the right coronary sulcus. It originates from the right coronary aortic sinus. That's just a fancy way of saying that there's a little hole here in the ascending aorta, and it's going to be emerging through that hole, and that's called the right coronary aortic sinus. So the right coronary artery has a bunch of different branches, but there's only a few key ones that you need to know. To be honest, you should know all of them, but there's only a few key ones that you're probably really going to be tested on. But first off, we have an immediate branch of this right coronary artery to supply the sinoatrial node. Then we have branches that are just going to be going to the right atrium and right ventricle. And then as we come down here, we have a right acute marginal branch of the right coronary artery, and this is going to help supply the right ventricle. You also have the right coronary artery continuing, and it goes posteriorly, and that gives us the posterior interventricular or posterior descending branch. It's also known as PIA for short. And you also have a branch to the AV node. So I believe this is the branch to the AV node. It's on the posterior side. Now, something important to note is the distribution pattern. So it's going to be supplying the right atrium, right ventricle. It supplies about 50-65% of the SA node's blood supply and 80-90% of the AV node's blood supply. That's not the most important thing, to be honest. The most important thing that you need to know is that it supplies the posterior 1/3 of the interventricular septum. And it makes a lot of sense if you think about it, right? We said that this is the posterior interventricular branch or artery. It runs posterior, and it's going to be stopping over here, which is where the interventricular septum is at. Okay, this is very, very important. This came as an SAQ last year, and you need to be able to identify the right coronary artery on an angiograph. Okay, that's what this is. Now, you have both the right coronary artery and the left coronary artery on angiographs, and you need to make sure you don't confuse yourself. So one trick that I came up with is if you look over here, it's kind of forming like a right angle almost, right? And it's the right coronary artery. So that's kind of just like what I thought would be helpful for you guys to remember it. And then, to be honest with you, there's only really two important things that you need to know on this angiograph. And that's, first of all, you need to know that this is the right coronary artery itself. And then you need to know that number 4, which is this over here, corresponds to the posterior interventricular artery, which is the PIA branch or PIA branch that we spoke about previously. And then, not as important, but you could help you if you know this. This is number 5. This is corresponding to the SA node branch. And number 9, which is this one, this is the AV node branch. But honestly, I don't think he's going to test you guys on that. The most important thing that you need to know is that this is what the right coronary artery looks like, and this is the posterior interventricular artery. Okay, so spoke about the right coronary artery, which runs in the right coronary sulcus, and this is the left coronary artery, which is going to be running in the left coronary sulcus. So let's just get straight into it. There are really two important branches that you need to know from the left coronary artery. First of all, there's the LAD, which is the left anterior descending branch of the coronary artery. So that's this one, right? And it's going to be covering the anterior surface. And then you have something called the circumflex branch of the coronary artery. And as you can see here, so this is the LAD. And then this is going to be going behind, and it's going to go and supply the posterior part of the heart. And something very, very important, again, that you need to know is that this supplies the anterior 2/3 of the interventricular septum. So this one supplies the posterior 1/3, right? The PIA branch, and this LAD is going to be supplying the anterior 2/3 of the interventricular septum. As you guys can probably guess, it supplies the left atrium and the left ventricle. It's around 35 to 45% of the SA node supply and 10 to 20% of the AV node supply. To be honest, it's not super important numbers, but you need to know this 2/3 and 1/3 thing for sure. Okay, so this is what it looks like on an angiograph. To be honest, it's very different from the right coronary artery, but just please don't mistake these two because some people do. And the most important thing that you need to know here is that 4, which corresponds to this is the LAD, and then 9, which corresponds to this is the circumflex artery, which is going to go posteriorly. Okay, those are the two really only important things I need to know. Okay, so the other thing that Dr. Atif spoke about in this dry lab is blockages in a coronary artery. So how do we visualize a coronary artery to begin with? Well, we insert a catheter through the femoral artery, which is in the thigh. This catheter then passes through the external iliac, common iliac, and all the way to the aorta. And once we reach there, we use a contrast dye for an angiogram, okay? And if this dye does not fill in, as clearly is the case here, right? It didn't fill in over here. It filled in over here, filled in over here, but didn't fill in over here. That means that there's a blockage. So for the blockage, there's a couple of different treatment options, and you should probably memorize this because I think it came as an SAQ last year as well. There's stenting, bypass grafting, and angioplasty. So first of all, I'll just talk about bypass grafting. So the whole concept of bypass grafting is you take a blood vessel from another part of the heart and you use it to kind of connect these two areas that aren't blocked, right? So the issue is over here. The blood isn't going because we have this blockage here. So we'll just circumvent it by bringing another vessel from another part of the body and attaching it between these two areas that are not blocked. And you should definitely know that commonly harvested vessels for this bypass is the great saphenous vein and the internal thoracic artery. These are the two that are used the most for bypass surgery. Okay, so we spoke about the different arteries. Now we're going to be speaking about the veins which accompany these. So first off, you have the small cardiac vein, and this is going to accompany the right marginal artery. So this is the right coronary artery. If you guys remember, then it branches off towards the end into the right marginal artery. And the small cardiac vein, all you really need to know is that it's going to be accompanying that, and it drains a portion of the right ventricle. Then you have the middle cardiac vein, and this is the posterior surface, by the way. And it's going to be accompanying the posterior interventricular artery. So again, another branch of the right coronary artery, but this time it's the PIA or posterior interventricular artery. And something that's important to know, all of these, by the way, they drain into the coronary sinus, right? And the coronary sinus is basically just a portion, it's just like a hole, I guess you could say, in the right atrium where blood is going to be, it drains directly into the right atrium, right? So it's not going to be going through the superior vena cava or inferior vena cava. It's just going to drain directly into the right atrium. And it drains the posterior of both ventricles and the interventricular septum. Okay. After that, we have the great cardiac vein. So the great cardiac vein is present anteriorly, and it accompanies the left anterior descending vein, or the LAD, right? It accompanies the LAD, but then it turns left upon reaching the left coronary sulcus, and it follows the circumflex artery to the posterior aspect of the heart, okay? And it enlarges into the coronary sinus again, so it's going to be draining directly into the right atrium, and it drains the anterior of the right/left ventricles and the interventricular septum. Okay, so these are some other cardiac veins. To be honest, they're not as important, but he could potentially ask you about them. So I'm just going to be going over them. This is the anterior cardiac veins. They're present, obviously, anteriorly. And all you really need to know is that they drain the anterior of the right ventricle. As you can see here, they're running alongside with the right coronary artery. Right? So they're right over here. Then you have the posterior cardiac veins. They're also known as the posterior vein of the left ventricle, and they drain the posterior aspect of the left ventricle. And if we go over here, yeah, this is the posterior cardiac veins. And you can see that they're like to the, I want to say right of the middle cardiac vein. And they're just going to help drain the posterior aspect of the left ventricle. Oh, and one more thing, you have Thebesian veins. So he definitely can't ask you about this on the OSPE because like they're everywhere in the heart, and they just drain the oxygenated blood from the heart wall directly into the chambers of the heart. So what I mean by that is obviously the heart wall itself, like it has cells that need to be supplied with blood. Once they're done with that blood, they have the oxygenated blood left over. So the Thebesian vein just drains those that use the oxygenated blood and throws it directly into the heart chambers. And the thing is that then that amount of blood is relatively small, so it can even go into the left ventricle and the left atrium, which has oxygenated blood, and mix with the oxygenated blood because it's such a small amount. It's not going to affect the oxygenation of that blood. Okay, so moving on to week two's dry lab. Week two's dry lab primarily focused on the different like features of the different chambers of the heart. So let's just get straight into it. So over here, we're looking at the right atrium, okay? The right atrium, both atria actually, have this like kind of rough texture surface, and this consists of pectinate muscles, okay? And it also has a smoother area. Now the ridge between these two, the ridge between the pectinate muscles and the smoother area is called the crista terminalis. So you need to know that. And then there's also the like intra-atrial septum, right? You have a septum between both of the atria, the left and the right. Obviously, you want that because one of them has deoxygenated blood and the other one has oxygenated blood. But there's this kind of weakening of the wall called the fossa ovalis, right? You can see that it's a bit thinner because if you shine light through it, the light comes out through the other side, right? Where it's not doing that for the rest of the intra-atrial septum. So what is the fossa ovalis? It's basically just a remnant of the foramen ovale. And the foramen ovale was present during embryonic life and helped shunt blood from the right atrium to the left atrium directly. And the reason why that's the case is because when you're still a fetus, you don't actually need to oxygenate blood because you're getting all of the blood, like you already have oxygenated blood coming from your mother. So you don't need to go through the process of pulmonary circulation, and instead you can just go straight into direct circulation. But when you're born, the foramen ovale closes, and this fossa ovalis is just a remnant of that. So now it is fused, but it's just a bit thinner over here. And then you have something called the atrioventricular orifice. It's basically just where blood is going to flow from the atrium into the ventricles. And between them, you have the tricuspid valve. So that covers pretty much everything for the right atrium that you need to know. This is just some other stuff. Oh, yeah. And this is the coronary sinus I was speaking about, right? So the veins of the heart, they're going to drain into this, and they're going to drain directly into the right atrium. And this is just the superior vena cava orifice. So it's basically just where the superior vena cava is going to, bring blood into the right atrium. Same thing with the inferior vena cava orifice. And this is the right ventricle, and this is the tricuspid valve that, helps support the atrioventricular orifice between the right atrium and the right ventricle. And again, this is just the pectinate muscles. You can see that it's very rough, as I showed you over here. And the crista terminalis, which is this ridge that separates the smoother muscle area from the rough pectinate muscles. Okay, so we covered the right atrium. Now let's move on to the right ventricle. So again, you have a similarly rough part on the right ventricle, but instead of calling it, it's not pectinate muscle this time. Instead, it's something called trabecular carne. Okay, And other than that, the other very important thing that you need to know in the right atrium is the septomarginal band, which just helps conduct electricity, right? And another, I don't know if I'll test you on this, guys, on this stuff, to be honest, but you should know that the valves themselves, like for example, we spoke about the tricuspid valve beforehand, they have something called papillary muscles and chordae tendineae, okay? So the papillary muscles help ensure that blood doesn't regurgitate back into the atrium when the ventricle itself contracts, okay? Because the ventricle contracts very powerfully, we want to make sure that this valve stays closed and we don't have any blood going back. This is obviously showing the left ventricle, and I'll explain the difference in a moment. But you can see that we have these papillary muscles, and then what attaches the valve to these papillary muscles is something called the chordae tendineae. So if we look over here, this is papillary muscles, a papillary muscle, and this is the chordae tendineae, and it's helping, stabilize the valve and make sure that there isn't any backflow. Okay, so what distinguishes the right ventricle from the left ventricle with respect to the papillary muscles is that the right ventricle has three, okay? So you have an anterior papillary muscle and a posterior papillary muscle. This is obviously trabecular carne. But you also have something called a septal papillary muscle. Now, the thing is, the septal papillary muscle is variable from person to person, from what I understand, but it tends to arise from the interventricular septum. So you can clearly see this is the septum, and it's originating from there. So it's very distinct from like the anterior and posterior papillary muscles, which don't originate from the septum. That's how you'd be able to tell them apart. And then anterior and posterior, you can obviously tell which one is closer to you. That's going to be the anterior one. Which one is further away, that's going to be the posterior one. Okay, so we had a look through the right atrium, the right ventricle, and now we're going to be looking at the left atrium. So this is the pulmonary orifice. Obviously, that's just for the pulmonary veins. The left auricle. Okay, so I forgot to cover this beforehand, but it's good that I can cover it now. Both atria have something called auricles above them, and you can basically just view them as extra storage space. They help store like extra blood. This is the left atrioventricular orifice, and then it's important to note that the left ventricle and left atrium are separated by the mitral or bicuspid valves. And yeah, that's what. Okay. So now we're going to be looking at the left ventricle. Again, it's relatively similar to the right ventricle. You can see that this is the smooth muscle part of the left atrium over here. And then you have the valve, which has these chordae tendineae and the different papillary muscles, right? The chordae tendineae are going to be helping support these papillary muscles. So you have the anterior and then the posterior, and then anterior papillary muscles. And like I said before, the right ventricle has 3 papillary muscles, but the left ventricle only has 2. Okay, and this was just like a nice picture. It shows the different heart valves, helps you remember them. So again, you have the mitral valve on the right here, tricuspid valve on the left. No, other way around, my bad. And then you have the aortic valve that's going to be between the left ventricle and the aorta, and the pulmonary valve is going to be between the pulmonary trunk and the right ventricle. Okay, so now we can get into the histo lab. I was told that people were struggling with this a bit, so I'll try to take my time and explain everything in depth. This is a type 1 artery, and it's known as a large elastic or conducting artery. So you'll notice that all of these have like 2 names. One of them is a functional name, so it's a conducting artery, and one of them is a structural name, so it's a large elastic artery. And we'll see why it's large elastic in a moment. The major example that you need to know, and you need to know these examples, is that of the aorta. Okay, the aorta is a type 1 artery, and it's called the large elastic artery because of the heavy presence of elastic fibers. So to be honest, like you can't miss this, right? Like it's very dense in elastic fibers and has a very unique look, you could say. You should know that there's more fenestrated elastic laminae, which is what this is, as opposed to smooth muscle. And then your lab slides also included the fact that in electron microscopy preparation, you can't see any smooth muscle cells because they're destroyed. I don't think that's that high yield, but I just put it for the sake of completion. And again, this is just an example of a large elastic artery. It's the aorta. If we zoom in, you can very clearly see like a large amount of elastic laminae. Okay, now we have type 2, which is the middle-sized muscular or distributing artery. And it has the like very telltale sign. And to be honest, this is probably like maybe the first or second easiest to tell apart from the rest of them, because it has 2 fenestrated elastic laminae, which no other artery has. So you have this internal elastic laminae and you have this external elastic laminae. Okay, and relative to the first one, you're going to have more smooth muscle as opposed to elastic laminae. An example of this is the ulnar artery. Now you should know that the internal elastic laminae, this is between the tunica intima and the tunica media. And then the external elastic laminae is between the tunica media and the tunica externa. Okay, moving on to type 3. These are known as small muscular or distributing artery/vein. So you can have small muscular artery or small distributing artery or small muscular vein or small distributing vein, right? That's the functional versus structural name. And an example of this are the digital arteries, so the ones that are in your fingers. You need to be able to distinguish between the artery and the vein here. So there's a couple of different things to note. First of all, the artery, the tunica intima has an internal elastic laminae, whereas the vein, it doesn't have any internal elastic laminae. For the artery, the tunica media is very thick and it's darker and it has more smooth muscle overall. And the lumen is like very round. Now, when we look at the vein, again, like I said, there's no internal elastic laminae. There's a very thin tunica media, as you guys can see here. This is very, very thin, relative to the tunica externa, which is very, very thick. Okay, so that's how you can tell them apart. And the lumen is collapsed, right? So it's obviously not round like how the artery is. She also wanted me to talk about this corkscrew nucleus, which just basically refers to the fact that when smooth muscle cells are contracted, they have a corkscrew shape, right? So you can clearly see that it's not like flat like this. It's more so like a corkscrew like this. So you should be able to tell when a smooth muscle cell is in contraction and when it's not. Okay, so this is type 4. We're almost there. This just refers to arterioles and venules. And it's not the most high yield thing ever. They're basically just used to help control blood flow. And an example of them is the vasa vasorum in the tunica externa of large blood vessels. So that basically just means that they are supporting blood vessels in the external wall of larger blood vessels, okay? And you should know that the arterioles are, again, like they're going to be, the lumen is going to be rounder, whereas with the venules, the lumen is going to be more collapsed like this. Okay, the last thing for this, and then I think we can get into practice questions, is the superior vena cava. So for the superior vena cava, the most important thing that you need to know is that the tunica externa is thicker than the media. This is pretty much, this is the only vessel, right? And your slide specifically notes as an exception. This is the only vessel that has it as that case. So the tunica externa is thicker than the media, and it's also darker. And that's because the tunica externa itself contains smooth muscle cells, which help prevent collapse when receiving blood. Because obviously, the superior vena cava receives a lot of blood. You don't want it to collapse when it's receiving that large amount of blood. So again, all of this is the tunica externa, right? It's super thick relative to, for example, what we saw here. This is the tunica media, and this is this is the tunica externa, right? So normally the tunica media is much, much thicker, but over here, the tunica externa is super thick and it's darker because it has smooth muscle cells. Okay, so this is checkpoint number 2. If you guys have any questions about anything that I've covered so far, whether it's from checkpoint 1 or checkpoint 2, you guys can go ahead and unmute and ask me right now. I'm sorry, I forgot about to ask you guys if you have any questions beforehand, but if you guys have any questions that you want to ask, you guys can go ahead right now. Nobody?
Hello.
Hello.
Is the endocardium, epicardium, its layers is mesothelium and submesothelium, right?
Yes, that's correct.
All right, thank you.
Okay. Is there anybody else? Otherwise, I'll just go straight into practice questions. Okay, I'm just going to go ahead and go into practice questions in that case. So can somebody please unmute and tell me what vessel this is and what is the vessel that runs with it?
This is the great cardiac vein, and it runs with the LAD, left anterior descending vein.
Good job. Okay, can somebody else please unmute and identify the type of blood vessel, give me both the functional and structural name, give me an example, and then give me an identifying feature of how you were able to tell what type of blood vessel this is.
Can I go?
Go ahead.
So this is a large elastic artery, which is the functional name. The other name is the conducting artery. Conducting artery. An example is the aorta. And an identifying feature is the mini elastic, fenestrated elastic lamella.
Yep, that's completely correct. Okay. Can somebody else unmute and tell me what X and Y are? What is the function of Y? And what can happen if Y over here doesn't work properly?
Can I?
Go ahead.
Y is a papillary muscle.
Yep.
X are chordae tendineae.
Yep.
The function of Y is to anchor the chordae tendineae, and if it doesn't work properly, during the ventricular systole, blood will flow back into the atria.
Perfect. Okay. So that's for the practice questions. Again, if you guys have any questions, whether it's about what I'm about to cover or from anything previously, feel free to unmute and interrupt me. I don't mind at all. But let's just get straight into week 3. So week 3's dry lab was about echocardiography, which is related to ultrasound. And just to give a brief summary of what ultrasound is, you're basically projecting sound waves onto a surface and seeing how those sound waves bounce back at you. And based on how those sound waves bounce back at you, you're able to generate an image. I hope that makes sense, right? Because, for example, if something is fluid, you'll get a darker or black image. And if something is, soft tissue, it's called hypoechoic. And if it's fluid, it's called anechoic. You'll get a grayer image. And then if something is bone or air, you'll get a white image, and it's called hyperechoic, right? So basically, just to summarize, you're projecting sound waves onto a surface or like an object, and you're seeing how they bounce back onto you. And based on that, you're generating an image. And the colors of that image are going to be dependent on the nature of the object that you're bouncing the sound waves onto. So that's how you end up with these 3 different colors. Okay, so now we need to look at the echocardiographic images of a normal heart. Okay, so this is assuming that we're bouncing sound waves onto a normal heart. What is the image that we're going to get back? And this is very, very high yield. I believe it came last year in the OSPE or in the SAQ. I don't remember, but it is very high yield. So the first thing to know is that the atrium are on the bottom here. I've never understood why this is the case, but you guys should just know that. And then from there, it's kind of straightforward, right? You know that the left ventricle is significantly bigger because, again, it's going to be pumping blood to the entire body. So it's this one. And then you have the mitral valve between the left atrium and the left ventricle. And then here on the right, or well, the patient's right, you have the right atrium and the right ventricle and the tricuspid valve between them. Again, guys, please remember that when we're talking about right, we're referring to the patient's right. Okay, so this is the right ventricle and right atrium, this left ventricle and left atrium. And then again, here you have the left ventricle. Always remember that it's significantly bigger. You have the mitral valve between the left atrium and the left ventricle, and you have the tricuspid valve between the right ventricle and the right atrium. And then there's something called the Doppler effect in echocardiography. It wasn't in your slides, but it was in your guys' lab guide, so I just went over it really quickly. If you see red, that means that blood is moving towards the transducer. The transducer is the thing that you're using to project the sound waves. And if you see blue, it means that blood is moving away from the transducer. Okay, so now let's get into capillaries. We're approaching the end of the anatomy lab and the anatomy/histol. So we'll be on to physio soon, inshallah. So first of all, a major indicator of capillary presence is the presence of a single RBC. Now, that's what I'm referring to over here, right? This is a single RBC in the capillary, right? That's how we know this is a capillary. Why is that the case? Because capillaries are actually so thin that when RBCs are passing through them, they have to pass in a single file line. So if you see a singular RBC like this, you automatically know that you're looking at a capillary. Something else that's important to note, if we zoom in over here, so this is a venule and this is an arteriole, right? We spoke about that previously as well. The nuclei of an arteriole, and I'll show you guys a better image in a bit, I think. I think I have a better image coming up. But you can see that the nuclei of like these capillaries, they're very flat, right? So the venule, its nuclei are extremely flat, whereas the arteriole, it's not all that flat. So that's something that, indicates that you're looking at an arteriole. And I guess you should also know that lymphatic capillaries, they're significantly wider than venules and arterioles. Yeah, so this is the image I was talking about. If you look over here, the arteriole, its nuclei are different clearly from this endothelium because this endothelium has like very flat nuclei, whereas the arteriole doesn't. And again, you should just know this is lymph in the lymph capillary. You should just know that it's relatively bigger. It should be fairly obvious if you're looking at it in the OSPE. And then this is just like another slide that I saw in the lab guide. This shows a capillary in the tongue, I believe. And this is a single RBC again in a capillary. I believe that's what we're looking at over here. Okay, this is relatively high yield. This can definitely come, so please pay attention, guys. This is referring to the different types of capillaries in electron microscopy. So we have three different types of capillaries. You have continuous/somatic, fenestrated, and then sinusoidal. So for continuous/somatic, you have, I mean, it's kind of in the name, you have a continuous basement membrane and plasma membrane, okay? So there's no leaking at all, right? You have the presence of tight junctions, which helps, occlude any potential leaks. And you also have the presence of something called pericytes, okay? This is very important. You should know that the pericyte is this one. And their importance is that they help with structural support and with cell-to-cell communication. Okay. And this F over here is just referring to a fibroblast, I believe. But the most important thing I need to know here is the pericyte, and that it's continuous because there's a continuous basement membrane and a continuous plasma membrane. Okay. And like an example of where you'd want to have a continuous or somatic like capillary is in the brain, because you don't want fluid leaking out into the brain, obviously. Then you have fenestrated capillaries, which are kind of the intermediate, right? You have a broken up plasma membrane, as you can see here, but you have a diaphragm, which helps cover up the fenestrae. And then the diaphragm, I believe, like things can come and go through the diaphragm. Because you have like a broken up plasma membrane. And you do have pericytes, but they exist at a lower frequency relative to the continuous or somatic capillaries. And you should know that diaphragm is made from glycocalyx. Okay. And then the last type of capillary is the sinusoidal capillary. So you have no diaphragm and you just have, like a leaky plasma membrane, right? It's not continuous, it's broken up. And you have no pericytes in this sinusoidal capillaries. An example where you can find this is in the spleen, because it helps RBCs exit and go out into the bloodstream. Okay, and then this wasn't in your guys' lab slides, but again, it was in your guys' lab guide from your lab committee, so I decided to include it as well. This is an arteriole, again, non-flat nuclei. I guess the most important thing that you need to know here is that the tunica media here, it contains these smooth muscles, and then the tunica externa/adventitia contains this fibroblast, right? Fibroblast nuclei. But you can clearly see here that this E is the nucleus of the endothelium of the arteriole, and it's not flat. Again, this is just another picture that was included. These are Weibel palliate bodies. I don't really think you need to know that. And these are pinocytotic vessels, which basically just help, the endothelium take in things through pinocytosis. Okay. So we previously touched on the mediastinum. We need to know that there's, a superior mediastinum and there's an inferior mediastinum, and that they're separated by the sternal angle. I'm not going to be going over all of these contents. You should know them for sure, but they're already covered in your guys' lecture. And for the sake of time, I'm not going to be able to go over them. And plus, they're more so just memorization. But you should know which vessel corresponds to which area, because it could definitely come as an OSPE question. So in your guys' lab slides, Dr. Atif went on to talk about the posterior mediastinum, and he gave us two different views. So he gave us an oblique left view and an oblique right view. Okay, so I'll just be breaking down this image and what we can see. So on the oblique left view, you can clearly see the descending aorta. That's what this is. The thoracic duct, which just helps collect lymph. And then you can see the azygous vein, right? I believe that's what this is. So a couple of different things to know here. The azygous vein gives off the right superior intercostal vein, which helps drain the first 2 to 3 intercostal spaces. And then it'll proceed to give off all of these different intercostal veins, okay? And something to note is that the order in which like veins, artery, and nerve exist in this intercostal space is van. So vein, artery, and then nerve, right? And you can see that here as well. Vein, artery, and then nerve, okay? Something else that's potentially very important is the sympathetic trunk. It's very tightly adhered to the posterior mediastinum, unlike the vagus nerve. So you shouldn't confuse the vagus nerve, because the vagus nerve will run anteriorly to the sympathetic trunk. And the sympathetic trunk has these rami communicants, which help the intercostal nerves communicate with the spinal cord through the sympathetic trunk. Yeah, that's pretty much all there really is to know here. You should also know that you have, what's it called? Intercostal arteries. you have posterior intercostal arteries and anterior intercostal arteries, and they anastomose together in case there's ever any sort of blockage, right? So that was more so focused on in your guys' anatomy lectures, but it could potentially come here as well. Now, this is the oblique right view, so we can't really see the descending aorta anymore, but we can see, we have a much better view of the azygous vein and the azygous vein system. So on the right side over here, you have the azygous vein itself. You have the hemiazygous vein, and then you have the accessory hemiazygous, which connects the hemiazygous to the azygous vein, right? So it helps it drain into the azygous vein. It's going to be doing that through the accessory hemiazygous. Again, you have the thoracic duct, which helps collect lymph. And you have the sympathetic trunk and the rami communicants, which help the intercostal nerves communicate with the sympathetic trunk. And again, just please remember vein, artery, nerve. Okay, this was included in your guys' lab guide. And I guess we're not looking at it from like an oblique perspective, right? Because oblique is obviously at an angle. We're just looking at it directly from the right side. So from the right side, you guys can clearly see the arch of the azygous vein. This is the heart. This is the diaphragm. And these are just the intercostal nerves. Again, they're going to be linking up with the sympathetic trunk. Then on the left side, you can clearly see the descending thoracic aorta. This is where you're going to be getting the posterior intercostal arteries, I believe. Don't quote me on that, but I believe that's where you're getting them from. And you have the intercostal nerves, which again are just going to be communicating with the sympathetic trunk here. Okay, this is very, very high yield. Like, he'll definitely bring something, at least like if it's not coming in the SAQ, if it's not coming in the OSPE, it's definitely coming in the MCQ, right? You need to know the development of the great vessel. So what I mean by that, to basically just break it down, you start off with, so let's just start off with the major veins first. What you need to know for this OSPE is that you're going to start off with the superior vena cava, which is this one, and it's going to go ahead and split, right? And when it splits, it's going to split into left and right brachiocephalic veins. And then those left and right brachiocephalic veins are going to continue into the right and left internal jugular veins, right? That's what these are. And right and left subclavian veins, which is what these are, right? So just to summarize again, you're going to start off with superior vena cava, right and left brachiocephalic, right and left subclavian, and then right and left internal jugular. And then for the arterial supply, you're going to have, it's a little bit different. You have the aorta. And then here on the right side, you're just going to be starting off with the brachiocephalic trunk. But on the left side, you're going to have the left common carotid artery and the right subclavian artery. Okay. So, Again, aorta. And then on the left, you're going to have the left common carotid and left subclavian. And here you're going to have the brachiocephalic trunk. And then later on, the brachiocephalic trunk is going to go and split into the right subclavian artery and the right common carotid artery. And again, I just inserted these two images because it's a bit cleaner than the model that's shown over here. But he could definitely bring a question where like he'll ask you to identify a specific vessel on a plastic model like this. So you should definitely know where everything is. Okay, yeah. So again, just quick summary: brachiocephalic trunk, right subclavian artery, right common carotid, and then directly you have directly left common carotid and left subclavian from the aorta on the left side. Okay, and then this is just, I wanted to include for the sake of completion what it would look like on a cadaver, just in case it comes on the cadaver exam. But there's something really important to note for your CVP OSPE exam is that the vast majority of questions will not be on a cadaver, right? You'll have like maybe 1 or 2 stations that have cadavers. Most of it is going to be either histo slides or printed out images or plastic models, right? So even if maybe they do include a cadaver, it's going to be like an image, like how you have over here, not the actual real life cadaver. So if we just look over here, we can start with the aorta. So you can clearly see the aorta is going to split up into brachiocephalic trunk. You have the left common carotid. For some reason, you can't really see the left subclavian here, but you can see left common carotid, brachiocephalic trunk. They're both originating from the aorta. That's this big, like very thick one. Then over here, you have the superior vena cava, and you have, the brachiocephalic veins splitting up like that. Again, I'm not sure how relevant this is to your guys' OSPE in particular, but you should probably know that this is the vagus and this is the phrenic nerve, right? So the phrenic nerve is a lot closer to the pericardium. As you can see, it's like directly adhering to it. And the vagus starts off a little bit more lateral, but then eventually comes like more medial and ends up being more medial eventually than the right phrenic, whereas the right phrenic kind of just continues directly on the same path. And again, this is just basically the same thing. Okay, this is actually the last thing for the cardio anatomy / histo, and then we're done. This is an aortography. I have no idea how to pronounce it, if I'm being honest. We kind of already covered most of this. What you should know is that, you know, you have the aorta, you have the ascending aorta, the arch of the aorta, descending aorta. And then obviously you're going to have, you know, right common carotid coming out of here from the brachiocephalic trunk. You're going to have left common carotid, left subclavian. Pretty much already like covered most of this. I guess what you should know is that the continuation, so number 6 over here, this is the axillary artery. It's just going to be the continuation of the left subclavian, I believe. A left subclavian artery. Or right subclavian artery, sorry. Right subclavian artery is going to continue on as the axillary artery. Oh yeah, and also another thing that could potentially come up is this 8 over here, this, you know, kind of thin one that's running behind. This is the internal thoracic artery. Okay, checkpoint number 3. Again, if you guys have any questions, feel free to ask. I'm more than happy to answer. If not, then we can go into practice OSPE questions. I'm guessing that means nobody. Okay, so could somebody please unmute and identify all of the different features on this echocardiograph? Anybody?
I can do that.
Go ahead.
Okay, so should you point at something and I say, or just say everything? Or
Yeah, sure. You can do that. So what am I looking at over here?
this is the left ventricle.
Okay,
The
great.
left
And
ventricle.
what is this? What is this over here?
This is the mitral valve.
Perfect. And what is this over here then?
Left atrium.
Okay, and what is this specifically?
Tricuspid valve.
Okay, perfect. And which of these features leads to the S1 sound upon its closure?
Both the mitral and tricuspid valve.
Okay. By the way, something that's important to note, they could potentially bring you questions that are from your lecture in the OSPE, okay? So like I didn't go over the S1 sound thing, but you should know that they could integrate questions together, right? Like for example, we just had our POD exam, and in our OSPE, they included stuff from the lectures that wasn't necessarily covered in the labs. Okay, so which structure is this red arrow pointing to? And which structure is this yellow arrow pointing to? Somebody please unmute and tell us. Anybody?
Should I go?
Go ahead.
So the red one is internal thoracic artery.
Perfect.
The yellow is left subclavian artery.
Not quite. I mean, it's a bit unclear here, but this is kind of more so pointing to the arch of the aorta.
Oh, okay.
But yeah, good guess. Okay, I think this is our last practice question. Could somebody please tell us what kind of capillary is this? Name 2 identifying features that help you identify this kind of capillary, and name a place where this kind of capillary is found.
Okay, can I go?
Go ahead.
So this is the sinusoid capillary,
Perfect.
and it doesn't have. I'm not really sure about the features, honestly, but I know
Okay.
it's not. It's in the spleen.
Okay. Would you like me to tell you the features then?
Yeah, sure.
There's a couple of different things that we could look at. For one, you have the broken up plasma membrane. There's also no diaphragm because, like, remember, in the other one, what is it called again? I can't remember right now. The one that isn't continuous and isn't sinusoidal. For some reason, my brain is...
Fenestrated.
Yes, fenestrated. Sorry, my brain just like completely blanked out. In fenestrated, we do have broken up plasma membrane, but you have a diaphragm. But here you don't have any diaphragm. And another important thing to know here is there's no parasites, right? That's something else that you mentioned. And it is indeed found in the spleen. Okay.
So no parasites, fenestrated, and no diaphragm.
Yep. So that's 3, but
All right.
like, you know, I thought I would just include an extra one. So we finished up with all of anatomy, all of histo, and now we just have this physio lab, and then we're done with the cardio section completely. Okay, I guess we should just get straight into it, and then we can take a break right after this, okay? So the first thing that you need to know for the OSPE, I guess this isn't the most important thing, but you guys should know that a normal sinus rhythm looks like this on the ECG, right? So like you have a P wave followed by a QRS complex followed by a T wave. And then the systolic, if you want to calculate like systole on the ECG, it's from the start of the QRS complex to the peak of the T wave. And diastolic is from the peak of the T wave to the peak of the next P wave, okay? Sorry, T wave to the peak of the next P wave. I think that's what I just said. But anyways, and again, you need to know that P wave followed by QRS by T wave is what makes it the normal sinus rhythm. صراحة, this is not the most important thing ever, but it was included in your guys' lab handout, and it's just what a ventricular myocyte action potential looks like. Okay, so there were a couple of different like situations or scenarios that your doctor gave you guys to like practice on in the lab. One of them was inhaling versus exhaling, and then he asked you to look at the difference in heart rate. So the first thing to note is that when you inspire or when you breathe in, you have an increased heart rate. So why is that the case? During inspiration, you have an expansion of the chest wall and your diaphragm is moving down, right? So these two factors combined together mean a decreased pressure in the thoracic cavity. Now, this decreased pressure, first of all, you're going to have an increased venous return because you have increased blood flow to the right atrium. And you have that because blood tends to flow from an area of higher pressure to lower pressure, right? And now all of a sudden, the intrathoracic cavity, it's significantly lower in pressure, right? You've significantly decreased the pressure because you expanded the chest wall and you had the diaphragm come down. So decreased pressure, now you're going to have more blood flowing to that area because blood flows from high pressure to low pressure. That means an increased venous return. But how does that mean a higher heart rate? So the thing to note here is that although you have like increased blood flow into the area, you still have a decreased pressure within the right atrium itself because the right atrium is in the thoracic cavity, right? And as a result, you're going to have decreased vagal or parasympathetic tone during inspiration, and you're going to have a takeover of the sympathetic nervous system instead, which is going to increase the heart rate. And then during expiration, you pretty much just have the opposite, right? So during expiration, as you guys can clearly see here, the heart rate gets much slower. There's a much bigger gap in between, each heartbeat, as opposed to inspiration, and that's because you have the opposite, right? So you have the compression of the chest wall, diaphragm moves up, increased pressure in the thoracic cavity, decreased blood flow to the right atrium, increased pressure, increased vagal and parasympathetic tone, and then parasympathetic is obviously going to lower the heart rate. Now, the other scenario that your guys' doctor asked you to experiment on is sitting versus standing. So when you're standing, blood is going to pool in the legs, and that's because of gravity, right? So if you stand up, all of your blood is going to go down, and it's going to pool in the legs due to gravity, and that means that you're going to have a decrease in blood pressure, right? I'm sure you guys have heard of orthostatic hypotension, which is basically like when you stand up and then your body can't compensate for that sudden decrease in blood pressure. But in this case, the person's body did compensate because the baroreceptors detected that there was a decrease in blood pressure, and as a result, they fire less, and then that in turn leads to an increase in the heart rate and vessel constriction, which helps to maintain the blood pressure and blood flow to the rest of the body. Okay, so how do we calculate heart rate in an ECG? This is relatively important. It could definitely come in the exam. So heart rate is just it's just the R interval, right? So one R to the other R, and you can approach it through two ways, right? Either you can count the number of small boxes, so that's like these ones, each individual one, between the two R's, and you do 300 divided by that number of small boxes, or you can do 1500 divided by the number of these larger boxes, right? So I'm referring to these larger boxes. And something else that's important to note is that, again, systole is between the start of the QRS complex and the peak of the T wave. So what you would do if you want to calculate the time that systole took is you would count the number of small boxes and multiply it by 0.04 because each small box is 0.04 seconds, okay? And then diastole is from the peak of the T wave to the peak of the next P wave. And again, you would count the number of small boxes and multiply by 0.04 to get the number of seconds that the diastole took. Okay, this is... is there something in the chat? Okay, it's true that you don't have... Okay, something important to note, your guys' OSPE is in real life, so there's not going to be any toolbox there with you guys. But for it being asked in the OSPE, they will give you like, okay, I don't think they'll ask you about the diastole or systole times, to be honest, because that would be a little bit rough. But they could definitely ask you for the number of like boxes. Like they'll give you an easy number of boxes, for example, right? So like 1500. Hold on, let me go back here. Like for example, 1500 divided by the number of large boxes, and then maybe they'll give you like 5 large boxes, right? Obviously, that wouldn't be the case because that would give you 300. That would be like that person's basically dead. But you get my point. They would give you relatively easier numbers to work through. Is that clear? Okay. Okay, so this is basically the last important thing. This is like very, very likely to come on the OSPE. This is the Valsalva maneuver. So the Valsalva maneuver refers to forcefully exhaling against a closed airway. So basically think of like, if any of you guys go to the gym, right? And like you've ever been really close to failure and you're like lifting, you're breathing out against a closed airway, right? That's what this is referring to. Or like when you're defecating, that's another example. And you do it for 10 seconds in this case. And then what this, so just to like break down this graph a little bit, you have before the gray, that's normal, right? So like you haven't done the Valsalva maneuver yet. Gray is during the actual Valsalva, and then after gray is post-Valsalva, so the recovery from Valsalva. Okay, so this over here is mean aortic pressure, and this is heart rate. And phase 1 is just going to be like, you're going to have an immediate increase in aortic pressure, right? Why is that the case? Because you're exhaling like very forcefully, and that's going to lead to a compression of the aorta because you have, decreased like volume and increased pressure of the chest wall, and the diaphragm is being pushed up, so the pressure on the aorta is increasing significantly. Okay, and to compensate for this, you're obviously going to have a decrease in heart rate, right? Because when your blood pressure increases, your heart rate decreases to help compensate for that. That's just the baroreceptor reflex. And then in phase 2, you're going to have an increased intrathoracic pressure, right? And as a result of that, you're going to have significantly less venous return. So what I mean by that, right? We've compressed the aorta so much that you can't even actually get blood out. And as a result of that, you're actually going to have a drop in aortic pressure because blood isn't going to be coming through to the aorta, right? So you're going to have a drop in the pressure. And as a result, you're going to have an increase in the heart rate, okay? And again, you should just like be able to, like you guys should just keep in mind that, the two are opposites, right? So if you're increasing your blood pressure, you're going to decrease the heart rate. If you're decreasing your blood pressure, you're going to increase the heart rate. They're antagonistic to each other. Now, what is 3 referring to? This is actually a very interesting thing to me personally. You have a further drop in aortic pressure. So if you look at 3, it's actually outside of the Valsalva maneuver. So at this point, we're recovering, right? And this is immediately after you stop the Valsalva maneuver. So what's actually happening immediately after you stop the Valsalva maneuver? You still have a decrease in the mean aortic pressure. Why is that the case, right? Shouldn't it be an increase? I mean, after all, you've stopped the exhalation now. The thing is, when you like stop the Valsalva maneuver, it's not like everything just goes back to normal all at once. Instead, you first have pulmonary vessels that are going to expand first. So the deoxygenated blood, right? The right side of the heart, the right atrium, the right ventricle, that's what's going to fill up first, okay? So you're still having a compression of the left side, so that includes the aorta, but the pulmonary vessels are, going to be expanding back first once you stop exhaling forcefully. And again, because you have a decrease in the pressure here, you're going to have a compensatory rise in the heart rate. But then after that, once you go back fully to normal, you're starting to recover, you'll have an increase in the aortic pressure because, like, again, you would have an increase in the aortic pressure, decrease in the heart rate. Yeah, because you have like all of the blood coming back through now, right? Because first you had the pulmonary side that's filling up, and now it's coming back over to the aortic side. So now you're gonna have a rapid rise in the aortic pressure because all that blood that we couldn't get out previously is now getting out to the aorta. And again, of course, you're gonna have a decrease in the heart rate as it's a compensatory baroreceptor reflex. Whenever you have an increase in the blood pressure, you're gonna have a decrease in the heart rate. Okay, this is the last thing, and then we're done. Again, I don't think this is going to come in the OSPE. It could definitely come in the MCQ, though. It's called Wiggers diagram. It was in your guys' lab handout. I'll just go over it very briefly. So we're looking at the ECG over here. Over here, we're going to be looking at the pressure, the heart sound, and then this is left ventricular volume, right? So first things first, you're going to have an increase in the, atrial pressure, right? Because you have atrial filling. And then at some point, the ventricle is going to start to fill with this blood from the atrium. And that's going to lead to an increase in the pressure in the ventricle, right? Because you have all this blood that's going to be flowing into the ventricle from the atrium. And then at some point, the pressure in the ventricle becomes greater than the pressure in the atrium, right? Due to the blood that's flowing in. And that's when you're going to have the first heart sound, because you're going to have the valve close, because you don't want regurgitation of the blood back. Then you're going to have pressure build up in the ventricle itself until it ejects all of this blood out. It's going to start ejecting the blood out. And then once the pressure is greater in the aorta, because it's ejecting the blood out, than it is the ventricle, you're going to have the second heart sound. And this is the closure of the aortic valve, because again, you don't want blood flowing back from the aorta into the ventricle, okay? And you can see that here with the left ventricular volume. Again, it's flowing, it's increasing, and then you have the closure of the valve, because you don't want blood flowing back from the ventricle into the atrium. And then you're going to expel it all into the aorta. And then this is ventricular diastole, which is just, you're going to have it filling up again. So yeah, and then over here, this just correlates to the ECG. Okay. So let's just get straight into the physio practice questions. Could somebody describe, could somebody please unmute and describe the phases in which the heartbeat increases and decreases in the patient in beats per minute, and what causes the sudden rise in heart rate in phase number 3 over here? Anybody? I'm more so just focused on this one, because this is definitely something that they could bring, since it's a bit of an anomaly if you when you're looking at it at first. Nobody wants to give this question a shot. This is definitely gonna there's a very good chance that the Valsalva maneuver is gonna come in the OSPE. It came in our OSPE. It's in the past questions. Okay. Well, I mean, what causes the sudden heart rate in phase 3 is that you have a continued decrease in the mean aortic pressure, and that's because you have the release from you stop exhaling, but you haven't yet had a recovery in the aorta. You only have the pulmonary vessels that are expanding right now, right? So you still have a decrease in the mean aortic pressure, and to compensate for this mean aortic pressure decreasing, you're going to have an increase in the heart rate. Okay, let's try this question now. During which phase does the sympathetic nervous system predominate, and which one is inhalation and which one is exhalation? And how can you tell? Does anybody want to unmute and try this question?
Yeah, I can do that.
Go ahead.
The sympathetic nervous system takes over in phase 1.
Okay, perfect.
And phase 1 is inhalation and phase 2 is exhalation, because phase 1 has higher heart rate. And that tells us that this is inhalation, because the heart rate increases during inhalation due to the negative pressure.
Okay.
Thank you.
Okay, so we are finally done with cardio. I think it would be appropriate to maybe take a 5-minute break. You guys can relax. If you guys have any questions right now, again, feel free to ask me about anything that we've done so far. Sorry. And I also just wanted to give you guys a word of advice. This is your guys' first in real life OSPE. And I know that at first that seems quite challenging and daunting, but to be honest, doing the OSPE in real life is actually much better than doing it online, because it helps you manage your time significantly. And everybody that I've spoken to, the vast majority of people around me would agree with that case, right? We were all very scared when we were going into our CVP OSPE for the first time. We're like, oh my God, it's going to be in real life. But in reality, it actually helps you manage your time much, much better. So don't be, intimidated by the fact that it's going to be in real life. What I will say, however, is please, guys, make sure you get a good night's rest before the exam. I know that goes without saying, regardless of whether or not the OSPE is in real life, but the worst case scenario is you haven't slept and then you're sitting in the PHA for 4 hours waiting for your group to go and do the IRL OSPE. You don't want that to be the case. So make sure you guys sleep well. And yeah, that's pretty much all I have to say. Yeah, I hope I benefited you guys. And again, if you guys have any questions right now, feel free to unmute. We'll take a 5-minute break, and then inshallah, we'll start Pulmo.
Okay. So you guys just went over the cardio part. I hope fun. Wasn't too much. You guys understood everything. Let's go into the pulmonary part. For this part, I'll be covering the anatomy. We'll also go over the cross sections, look at anatomy, and also radiology. And then we'll take histo and then the physio part. Histo and physio are honestly very, very simple. They should not take that long. The bulk of this is going to be the anatomy part. Okay. Okay, I think my laptop's lagging. Okay, there we go. So first, we'll talk about the nose, the larynx, and then we'll move on to the trachea, the bronchi, lungs, and the pleural. And then we'll move to the cross sections. There's going to be the CT, and then there's anatomy, which is like the real person cross sections. And then finally the X-ray, and this will cover the anatomy part. Also, guys, I can't really open the chat, but if there's anything, try to unmute maybe. Yeah, and please try to be as interactive as possible. Like, I really, really want you guys to be engaging. Let's start with the nasal section, the nasal cavity. Remember this histo cross section because we'll go to it again later on. The nasal cavity is divided into three main regions. We have this part, which is the vestibule. It's basically the opening into the nasal cavity. We have the olfactory region here, which is located at the apex of the nasal cavity, and this respiratory region. We'll talk about the olfactory region and the respiratory region again in the what is it called? The histo part. The respiratory region is lined with pseudostratified columnar epithelium with goblet cells. Again, we'll cover this again in histo part. So the main part of the nasal cavity is that you need to know the conchi and the meatuses. Now, what are conchi? Can someone tell me what conchi are?
Bony projections on
Bony projections. Okay.
lateral.
So they're bony projections coming from the lateral wall. Just to orient ourselves a little bit better, this is the lateral wall of the nasal cavity. This is the medial wall, and it's the septum. So they're coming off from the lateral wall. And we have three nasal conchi. We have the superior conchi, we have the middle conchi, and the inferior conchi. And their main purpose is to increase the surface area, and they're allowing for the warming of the air, the humidification, because we don't want the cold air to reach our lungs. These projections are going to be creating these spaces that you can see here. They're colored in yellow. And the spaces are called meatuses. And we have three, again, same name, superior, middle, inferior. And they receive drainage from the paranasal sinuses and from the nasolacrimal duct. We'll talk about these two later on. But Sandy, for now, let's keep going. Okay, paranasal sinuses, we have four main ones. These are basically air-filled cavities, and they're found within certain bones that open into the nasal cavity. And they're named according to the bone that they're found in. So we have the frontal sinus, which is in the frontal bone. We have the ethmoid sinus, ethmoid bone, maxillary sinus, maxillary bone, sphenoid sinus, sphenoid bone. And these sinuses are going to drain into different meatuses. Now, I remembered their location. We have frontal, I remembered F for forehead because it's at your forehead. Ethmoid, it's between your eyes, so E for eyes. For maxillary, because I couldn't think of anything other than the fact that they're kind of located near your cheeks. And I have cheeks, and my name's Manal, so M for M, you know. And then we also have the sphenoid sinuses here. And when I was looking at this diagram, I thought that they're close to your ear. Someone, this was last year, no. I thought that they were close to your ear. So I was like, okay, what do I listen to in my ear? I listen to music on Spotify. So this is how I remembered it. But then I realized that this is not even near your ear. But this is not anatomically correct, okay? But this is just how I remembered it. Okay. The most important part here is the drainage of the paranasal sinuses. We said that they drain into different meatuses. And we said that we have three meatuses, the superior, middle, and inferior. Most of these are going to drain into the middle meatus. So this makes it very easy to memorize. Just memorize the exceptions, and then the rest are middle meatus. So frontal here is going to be middle meatus. Ethmoidal sinus has three different parts. You don't really need to know where they're located or anything, but just know that the different parts drain into different areas. The anterior and the middle part drain into the middle meatus. Posterior is an exception. It's going to drain into the superior meatus. We have the maxillary sinus here, and it drains into, again, middle meatus. We have the sphenoid sinus, which is found over here. And this is our nasal cavity. This is the sphenoid sinus. It drains into something called the sphenoethmoidal recess. Now, where is this? It's found here. Can you see this circle? I think I'm zooming in. Yeah. This part is the sphenoethmoidal recess. This is where the sphenoid sinus is going to drain into. is this all clear so far? Perineal sinuses and where they drain? Okay. We'll keep going. Other than the paranasal sinus, we mentioned the nasolacrimal duct. And what is this basically? This is going to drain your tears into the inferior meatus. You don't have to know much about it, just know that nasolacrimal duct drains tears into the inferior meatus. We also have the auscultation tube or the auditory tube. It's located here. It turns into the nasopharynx and it's posterior to the inferior meatus here. And this basically allows the middle ear to equalize the air pressure with outside. Because is not really, there's nowhere else to put it. So, okay. I want you guys to practice the meatuses and the concha and their naming. So if someone can tell me, this one right here, the one that I'm pointing at right now, which concha is this? Arshad, if you can unmute, that would be great. Okay, this is no one replied this. Okay, this is the inferior meatus. This would be superior. This would be middle. This would be concha. This would be superior concha. This would be middle, and this would be inferior. You can also see them here. They're the protrusion and the cavity point. Okay, I think that's it for the nasal cavity. Oh, we have one more point.
Sorry, it's lagging.
We have the cavity. Oh, can you guys not hear me well?
We can't see the screen.
We can hear you well, but the screen's lagging.
Oh, okay. Let me give it a minute. Let me know if you can see it well. I'll try changing my internet. Give me a minute. Can you guys see my screen well now? I changed my internet connection.
Yes.
Okay, great. Last part is the Kesselbach's plexus. Now remember how initially we said one of the functions of the concha was to warm and humidify the air. So how is it going to be warmed? We have blood vessels in the nasal cavity, and their main purpose is for heat exchange. So it's going to warm up the inhaled air before it gets to the lung. I don't think this is crazy necessary for OSPE, but I included it just to make sure everything's there. So we're done with the nasal cavity, moving on to the larynx. Before we go, do you guys have any questions, anything that's not clear, anything that you didn't hear, maybe when it was lagging?
Could you please quick repeat about the superior and inferior and middle one?
Okay, let me go. We have concha and we have meatuses, okay? We have superior concha, we have middle concha and inferior concha. And each concha is kind of like a projection from coming out of the lateral wall. It's a bony projection. And because there's like kind of a bump, and a bump is going to form a cavity or a space. And this space is a meatus. And this space is going to drain fluid. It receives drainage from sinuses. We mentioned sinuses earlier. Do you know them? Do you want me to go over them again?
Thank you.
These are the
Excuse me.
paranasal sinuses.
Could you repeat the sinuses quickly?
Yeah, I'll go over the sinuses. That's just okay. Superior concha, middle concha, inferior concha. Same thing for the meatus, same name. Now, for the sinuses, we have 4 paranasal sinuses. We have frontal, we have ethmoid, and we have maxillary and sphenoid. Now, what are they exactly? They're basically air-filled cavities, and they're found within certain bones that open into the nasal cavity. For these air-filled cavities, they're going to have maybe fluid or whatever, and it drains into the meatuses. For frontal sinus here, frontal sinus will drain into the middle meatus, which is this part here. We have ethmoid sinus. It has different parts, and the different parts drain into different meatuses. You don't really need to know the different parts, just know which drains where. And you don't need to know where they're located, just know which one drains where. For the anterior and the middle, both drain into the middle meatus here. The middle meatus is kind of like the big boss of meatuses because everything drains into it, most of the things. We have certain exceptions that don't drain there. Posterior is going to drain into the superior meatus, this part here. Maxillary drains also into the middle. Sphenoid sinus is an exception again. It drains into the sphenoid ethmoidal recess, which is this part here. This is the sphenoid sinus, and it drains here. All clear?
Yes. Thank
Okay,
you.
good. For the larynx. Now, the larynx is basically our voice box. Its main function is phonation, and anatomically, it's divided into 3 parts. We said the main function is phonation, for we're going to divide it according to where the vocal cords are located. The vocal cords are located here in the glottis. And according to that, we divide the rest. So anything above this glottis is in the supraglottis. Anything below the glottis is subglottis. And And for the larynx, it's lined with ciliated pseudostratified columnar epithelium, with the only exception being the true vocal cords. And we'll talk about true vocal cords in a minute. And these are going to be lined with stratified squamous. This was mentioned in your lab manual under larynx, but it wasn't mentioned in the histo section, so I thought I'd include it here. Okay. The epiglottis, I hope you guys know what the epiglottis is. If you don't, you're discovering it now. This is the epiglottis, and it's a piece of cartilage, and it's going to close when you're swallowing to prevent any food from going into your trachea. This part right here. We have something called the false vocal cords or the vestibular folds, and it's located here, this part right here. And this basically, the function is not crazy important. It acts like as a second seal, closing the laryngeal cavity. And we also have the true vocal cords. This is like the most important part here, which is located right here. I hope you guys can see the arrow I'm pointing. This is going to completely seal the airway, because nothing can go past it, and it's also responsible for phonation, for us speaking. This is the most important part of the larynx. Both of these vocal cords, the false vocal cords and the true vocal cords, are going to be attached anteriorly to the thyroid cartilage, posteriorly to the arytenoid cartilage. We'll talk about the cartilages in a minute. I'm just including it here as well. These 3, epiglottis, the false vocal cords, and the true vocal cords, are forming something called sphincter tears. I don't think this is very, very important, and we didn't take it in my lab last year, but I'm including it again because it's there. These together, and these 3, are going to make sure that no food gets into the trachea. Okay. Again, just pictures showing you guys. This is how it looks overall. This is our epiglottis. This is the false vocal cords, and these are the true vocal cords. This is a close-up, and this is a close-up from your lab. Okay. Now let's talk about the laryngeal cartilage. Now, how is this cartilage divided? We have unpaired ones and we have paired. Unpaired, and it's just one. Paired, it means that we have 2 of it. So the unpaired ones, we have the epiglottis, which is the green one here. We talked about it earlier. We have the thyroid cartilage, which is like the biggest part here. It's the reddish pink one. And we have the cricoid cartilage, which is this yellow part here. Now, this kind of goes as a ring all the way around. This is from the front and this is from the back. It forms sort of a ring around the whole structure. And the thyroid is found anteriorly. Okay. For paired structures, we have the arytenoid, we have the corniculate, and they have the cuneiform. We'll talk about them more in a minute. Arytenoid is this blue part here, these 2. The corniculate are found on top of the arytenoid, and they're forming these tiny bumps. Cuneiform is irrelevant, don't even acknowledge this one. I don't even know where it is. Okay. Again, we said true and the false vocal cords anteriorly are attached to the thyroid cartilage here, which is, again, this one, and posteriorly to the arytenoid cartilage, this part here, and the blue parts here. All clear? I'll show you guys on here as well. Again, thyroid cartilage, it's found anteriorly. And how do we know that we're looking anteriorly as well? We have the trachea. We have the rings of the trachea here. So this tells us that we're looking anteriorly. We have the thyroid cartilage here. Underneath it, we have the cricoid cartilage. We said that it goes all around it. So we also see it here, cricoid cartilage. And we have the arytenoid cartilage here with the corniculate cartilage on top of the arytenoid cartilage. Is the cartilage clear? Before we go to the muscles? Yes. Great. Muscles, which is the most important part. Now, in your lab manual and in your objectives, you guys only have to know two main muscles. But this is very, very, very important. Yani if they ask questions about laryngeal muscles or anything about the larynx, actually, they're going to ask about this, okay? You need to know the posterior cricoarytenoid muscle and guys, I got kicked out and I don't know where I stopped. But if you can let me know where I stopped, I'll continue. And if the host can please let me share my screen, that would be great. And can you guys see my screen? There's so much technical difficulties, it's not funny. But can you see my screen?
No.
No, okay. Let me stop sharing and share again. Can you see it now?
Yes.
Yeah.
Okay. Do you see it completely or are there like small parts covering part of the screen?
No, it's clear.
Okay. Can you guys just let me know where we stopped before
From
I
when you
got
started
kicked out?
the laryngeal muscles.
Okay, I'll start over. I was saying the laryngeal muscles are very, very important. And if they're going to ask you guys anything about the larynx, it's going to be the laryngeal muscles. Okay. Now you only have to know two. I checked your lab manuals and I checked your objectives. These are the only two that were mentioned. They're the only ones that you have to know. Don't try to memorize the names of cava. Like try to break down the names and properly understand them so that they actually stick. We have posterior cricoarytenoid muscle. If it's posterior, this tells us that it's to the back. Cricoarytenoid. So crico, we said cricoid cartilage, arytenoid cartilage. So it's going from the cricoid cartilage to the arytenoid cartilage. And it's in the back because posterior. Its function is to abduct the vocal cords, and it's getting innervated by something called the recurrent laryngeal nerve. And if this were to get damaged, it would cause hoarseness to the voice because this is abducting our vocal cords. If we can't abduct the vocal cords, it results in hoarseness. For cricothyroid, again, we'll break down the name cricoid. crico for cricoid, crico for cricoid, thyroid for cartilage. It's like the crico, and this is found anteriorly because we said the thyroid cartilage is anteriorly. The main function of this muscle is to tense the vocal cords. It's innervated by the superior laryngeal nerve, and if it were to get damaged, we would have monotonous voice. أنا بصراحة when I was going over it, I couldn't properly compare, like in first year, I had a problem understanding the difference between abducting the vocal cords and what is it called? Tensing the vocal cords. It's not very important, but for you guys to be able to visualize it, what this muscle does, the posterior cricoarytenoid muscle, is that it abducts them and it looks like this. And for the cricothyroid, it's going to stretch the vocal cords. For when you're stretching something, you make tense. So it tenses the vocal cords. And the recurrent laryngeal nerve is coming from down all the way here, and it goes back to supply the posterior cricoarytenoid muscle. And superior laryngeal is coming from the top, and it's coming to supply cricothyroid muscle. Just know the muscle, the nerves, and what happens if they get damaged. If you're not getting this in OSPE, you're getting this as an SQ, not SQ, as an MCQ for sure, because it's very, very important. Now I have a question. And if you don't want to read that, just answer the question. Let's see which one. Middle meatus, frontis, and sinus. صح, amazing. That would be correct. Middle meatus, frontal maxillary are examples. Another question. Does anyone want to answer that one? Okay, abduction of the vocal cords. Which nerve recurrent laryngeal? Amazing. So all clear? Are we good to go? Have any questions? So now we'll talk about the bronchi, the lungs, and the pleura, and also the diaphragm. This is going to, my internet connection is unstable. Can you guys hear me?
Yes.
Okay, great. If it stops, let me know. For the trachea, now the trachea is going to begin at the lower part of the cricoid cartilage at C6, and it goes all the way till the sternal angle, which is at T4, T5. You guys know what the sternal angle is. Took it in the mediastinum lecture. I'm assuming that you know the sternal angle. Okay, so the trachea is going to be held open by C-shaped cartilage rings, and we have approximately 16 to 20. Can you see them? They're C-shaped cartilage. Again, we'll talk about this more in here. And the point in which it bifurcates, we're going to see something called the carina, which is a ridge of cartilage that's seen inside of the trachea. We'll see this in the next slide. But the main purpose of having these C-shaped cartilage rings and the trachea is to keep the airway open and to allow for flexibility. Okay. So anteriorly, we see the rings. Posteriorly, it's a C-shaped ring. In the back, we don't have anything. It's not cartilage. You can see here. It's just muscle. And this is the carina, which is the point of bifurcation. We're going to have a cartilage inside of the trachea, and when we're splitting it to the right and left, mean bronchi. Okay, and you can see in trachea, this part does not have cartilage because it's going to be next to the esophagus. Clear? Do I move on to bronchi?
Yes.
Oh. So we said the trachea at this point of the sternal angle is going to split into the right and left main bronchi. Okay, and then the right and left main bronchi here. The right one and the left one. And then this right one is going to split into two. So we have the primary bronchi or the main bronchi, the right and left ones. And this is going to split even more into secondary bronchi. We have three. We have the superior lobular bronchi, the middle lobular bronchi, and the inferior lobular bronchi. Okay, bronchi is plural of bronchus, it's the same thing. And for the left side, it's the same thing, except that we only have two secondary bronchi. We don't have the middle lobular ones. And this is because the left lung has two lobes, whereas the right lung has three lobes. We'll see this in a few slides. But yeah. So bronchi will not bifurcate. The right main bronchi, this one here, is shorter, wider, and more vertical than the left one. Why is this important? This is clinically important. Why? Because when someone aspires an object, it's more likely to go directly into the right main bronchi. Because it's more vertical and it's wider. For an object, it's more likely to go there rather than the left side. And I think everything here is already mentioned. Plus, the secondary bronchi, we just mentioned them, superior, middle, inferior, and on the left side, superior and inferior, are going to split into even more bronchi, which are called the tertiary or the segmental bronchi. Now, for the right lung, there are 10 tertiary bronchi. But it's very, very easy to remember once you break it down. فقلنا عندنا the superior lobe, middle lobe, inferior lobe. These were our secondary bronchi. For each one, we're going to take a look at the tertiary bronchi, and each one is going to split into different ones. The superior lobe is, the superior, what's it called? Superior bronchus is going into the superior lobe of the right lung. And then it's going to split into three. Apical is going to the apex. This is how I remembered it. Anterior goes anteriorly, posterior goes posteriorly. So these are the three ones found in the superior lobe. And then the middle lobe, and it's just going to be sideways. So we have a lateral one and a medial one. Do you guys know the difference between lateral and medial? I don't know why I had a problem with this. This makes everything 1,000 times easier to know the difference between. Medial is basically closer to the center of the body. So this one is more medial to the body. This is how you identify. For the inferior lobe, we have 5. Inferior lobe ones are going to be the same in the left. So how I remembered it is by looking at this pyramid. If you look at the arrows here, these look exactly like a pyramid. Number 6, which is going to the top, is the superior part. It's called superior. And then 7 is part of the base, but it's going to the front. So it's anterior basal. Basal means base. And then 8 goes to the back, again, part of the base. So it's posterior basal. 9 and 10 are lateral and medial. So this is medial, this is lateral. Are we clear on these? Do you want me to go over any of them? Yeah, I'm back. Let's go to the left one. Now here we have 9 rather than 10 because we only have 2 lobes. So the division is a bit different. Inferior lobe, exactly the same thing as before. The one that differs is the superior lobe. Here we have 4. How are we going to divide it? We have the apical posterior. So it's kind of going up, but it's also going back. So it's apical posterior. It's this one here. And this one is anterior. It's going to the front. These two are together. And then 3 and 4 are superior lingual and inferior lingual. On the left lung, we have something called the linguala. So these are going to supply that part. Inferior part, same thing as we mentioned before. And if you guys can, and whenever you're free, go over these, try to make sure that you can identify them. They're exactly the same thing that we just talked about. This is a clear picture for you guys to identify them. Are they clear? Are the bronchi clear? Do you want me to go over anything again?
No, it's clear.
Excuse me.
Yeah.
Where's the inferior bronchi?
In general or here?
In general.
Let me go back. But there is nothing called inferior bronchi. We have the inferior lobe. Oh, because like the inferior bronchi. Okay, sorry, my bad. Inferior bronchi is opening into the inferior lobe. So superior bronchi is opening into the superior lobe. Middle bronchi is opening to the middle lobe. Inferior bronchi opening to the inferior lobe. So it's going here. Both sides, right and left, are going to be the same thing. I mean, the inferior bronchi is going to divide into these 5. Does that answer your question?
Yes, thank you.
Okay, now moving on to the lungs. Now, the lungs, you guys are getting a question on this, okay? They're going to bring you along probably, and they're going to ask you to identify if it's right or left, and then maybe give an identifying feature, something like that. So you need to be able to tell if this is a right lung or if this is a left lung. Now, how do we do that? you need to be able to, how I did it is I looked at the borders. You need to be able to look at the borders to properly identify, okay, this is right, this is left. So we have the anterior border, which is this front part here, and it's kind of a sharp border. Actually, let's talk about the surfaces first, okay? We have the costal surface, which is the surface that's facing the ribs. Okay, we have the mediastinal surface, which is the surface that's kind of facing the heart. It's facing the hilum of the lungs. So this is the mediastinal surface. And then we have the diaphragmatic surface, which is the one where the lung is in contact with the diaphragm. It's basically the base of the lung because the lung is sitting on the diaphragm. It's the diaphragmatic surface. So now that we know the surfaces, we go into the borders. Anterior border is basically this part here. It's between the costal surface and the mediastinal surface. Now we can tell that this is anterior, whereas the posterior one, it's also between the costal and the mediastinal, but it's kind of round. It's round is posterior, sharp is anterior. And the inferior border is basically separating the costal surface and mediastinal surface from the base. Okay? And in the right lung, we said that we have 3 lobes: the superior lobe, middle lobe, inferior lobe. For the left, we have 2 lobes. These lobes are divided by these lines here, and these lines are called fissures. We'll talk about it in a minute. Okay. So these are here. The lobes, fissures, the right lung, 3 lobes, we said, middle, superior, middle, inferior, and 2 fissures dividing them. Left lung, 2 lobes, 1 fissure. Because in 2 lobes, there's 1 line dividing the 2 for 1 fissure. Okay. Also, on the lungs, we need to note the impression. So the 2 lungs are facing each other, and let's say the heart is on one side. Coming out of the heart, we have the aorta, the arch of the aorta. All of these structures are very close to each other, so they're going to leave some kind of impression on the lung. So here, this is going to be the impression formed by the aorta. You can see it's very deep. But this is the left lung. So if you guys get a left lung and they ask you what's an identifying feature that tells you that this is the left lung, we can see the impression from the aorta, from the arch of the aorta. For on the left lung, according to your lab manuals, we see the arch of the aorta and left subclavian artery. The one that you can actually see is the arch of the aorta. On the right lung, we can see the superior vena cava and the arch of the azygos. They're not likely to ask you to find the superior vena cava impression or arch of azygos impression. This arch of aorta very likely. So let's talk about the right lung. Now the right lung is larger than the left lung. Why is that? On the left side, we have the heart, and the heart is very close to the lung. There's not enough space for the lung to be huge and for it to be. On the right side, we don't have the heart, so it's going to be larger. And this is also what's causing the 3 lobes. We have the upper lobe, or the superior lobe, we have the inferior lobe, and the middle lobe. Now, we said that they're divided by fissures. So between the superior one and the middle lobe, we have a horizontal fissure. You can see also it looks horizontal. And between the superior lobe and the inferior lobe, we have an oblique fissure. So this is horizontal fissure, and this is the oblique fissure. Okay. And at the hilum, another thing that you guys need to know is at the hilum, the order in which the structures are piercing the lung. So in the right lung and in the left lung, they're different. In the right lung, this is the order, BAV. Now, how I remembered it is that B kind of looks like the letter R. So B is going to be first in the right lung. First, we're going to have the right primary bronchus. It's going to be going into the lung. And then we have the pulmonary aorta right here. And underneath it, we're having the 2 pulmonary veins. So they're following the order of BAV. B, A, V. This is the order in the hilum. And I put the pictures here without labels in case you guys want to practice labeling it or anything. For the left lung, we said that it's going to be smaller to accommodate for the heart. And we only have 2 lobes. So showing you the lobes. We have the superior lobe and the inferior lobe. Because we only have 2 lobes, we said fissure, which is the horizontal fissure. So both lungs are going to have a horizontal fissure. The additional one on the right lung is the oblique fissure. So here we have horizontal fissure. Now also on the left lung, we have certain distinctive features. We have the cardiac notch, which is basically a depression for the heart. You can see it a bit more here. Can you see this depression here? This is the cardiac notch. And we also have something called the lingula. Can you see this part? It's kind of like a flap, and they use it to sometimes to confuse you, because you might think, okay, this is a middle lobe, but it's not the middle lobe, it's the lingula. And this is why you try not to differentiate the 2 lungs with the middle lobe and the lingula. Try to differentiate them with the borders. So the lingua is also formed in the left lung, and it's kind of a tongue-like structure, and it's found below the cardiac notch. And it's not very, very relevant. It's kind of increasing the surface area in the lung. It's not crazy important. Okay. The order at the hilum for the lung is A, B, V. We said the right lung was BAV. Here it's A, B, V. A, first we have the pulmonary artery here. Underneath it, we're going to have the primary bronchus, and then we're going to have the two pulmonary veins. First artery, then bronchus, and then the two pulmonary veins. And again, the labels. I'll keep going. Now, the plural is not really important for a lab. Just not mentioning it anyways. It's there in your lab manual, and it's in content to begin with. Someone said something in the chat. Superior and inferior lobe is separated by the oblique fissure. Yes. Thank you, Amma, for confirming. Okay. So for the pleura is basically it's a pair of double layered membranes, and they're very thin, and they're basically protecting and they're cushioning the lungs. It's kind of like the heart. We had something very, very similar to it. But here we have the visceral pleura. It's going to be very, very attached to the lung surface, and it covers each lobe, and it also goes into the fissures. So it's covering the lobes, and it goes into the fissures. So every surface of the lung is going to be covered by a visceral pleura. Now, this one does not have any sensory nerves, but it's insensitive to pain. It does not feel anything. For the parietal pleura, here we have the visceral and then parietal. It's the outer layer, and it lies to the inner surface of the thoracic wall. It's right underneath the thoracic wall it's innervated by intercostal nerves and the phrenic nerves. So this makes it sensitive to pain. Visceral, no sensory innervation, so it's not sensitive. While the parietal, it has the intercostal nerves and the phrenic nerves, so it's sensitive to pain. And between the two, we have the pleural space. The pleural space, or the pleural cavity, is basically a thin filled space between the two layers. It's going to contain a small amount of serous fluid, and the main purpose is for lubrication. It allows the lungs to move properly when you're inhaling and exhaling, prevents friction, and it has a lot of roles, but they're not crazy important. Okay. Now for the diaphragm, pleura is very simple. For the diaphragm, this is very important, very likely to get a question on this. The structures that pierce the diaphragm, what level they pierce the diaphragm at and where. So they might bring you the diagram and ask you to label it. They might ask you which structure is going through here and at what level, these kinds of things. So we have inferior vena cava, we have the esophagus and the aorta. Inferior vena cava is going to go in first. It goes at the level of T8. And then we have the esophagus at T10, and finally the aorta at T12. So here, if I were to ask you to label them, 1 would be for the inferior vena cava at T8, 2 would be for the esophagus at T10, and 3 would be for the aorta at T12. You can see it here again. Superior. Now, why is the inferior vena cava, why is it important to know it's going through here and not through the muscle? Can someone tell me?
So that doesn't constrict when the muscles are contracting?
Amazing. So when you're inhaling, it does not constrict. That was perfect. It's in the central tendon, so it's not going to get any constriction. So are the levels clear? Which structures are going through which? Clear?
Sorry, could you repeat again?
Okay. So we have, for the diaphragm, we need to think about 3 different structures that pierce through the diaphragm. And they're going from the top through the diaphragm. We have the inferior vena cava, we have the esophagus, and we have the descending aorta. Now they're going at different levels, different vertebral levels, and they're going to different locations. Inferior vena cava is going to go through here, through the central tendon, at the level of T8. Esophagus is going to go at the level of T10, and it's going through the muscle, it's fine. Whereas the descending aorta is going to go at T12. Now, descending aorta is very close to the vertebra family. If you see something next to the vertebra, it's the descending aorta. Is that clear?
Yes, it's clear. Thank you.
Last part in the diaphragm is the innervation. The diaphragm is innervated by two nerves, the left phrenic and the right phrenic. So basically phrenic, left and right. And by two arteries, we have the internal thoracic and the muscular phrenic artery. And it's just memorization بصراحة. Phrenic nerve, internal thoracic artery, muscular phrenic artery. Question. Can anyone read or answer?
Superior vena cava.
Okay, inferior vena cava, صح. And what vertebral level does it appear?
T8.
T8, amazing. And can you mention two nerves? I mentioned it. No one's had to go for it. Two nerves supplying structure Y. This one.
Right and left phrenic nerves, and you also have intercostal nerves, I think.
Amazing, صح. Answers. Okay, another question. Which lung is this? And what are two characteristics to justify your answer?
This is the right lung,
Okay. And what are two
and
characteristics?
horizontal fissure and middle lobe.
صح. Amazing. But it would actually be oblique fissure because horizontal fissure is also present in the left lung. It's amazing.
You made a mistake. Yeah. You said that horizontal fissure is also present in the left lung. You meant that.
Oh, yeah. Okay.
Yeah.
Yeah. Okay. My bad. Okay, last question.
Is it
عادي, try.
the
حتى if you get it wrong, it's fine.
yeah? Is it the archivazygos and superior vena cava?
Yes. Right. Ladies and sphere. Oh, I showed you guys the answer. Okay, and which level does wonder? Actually, this is not part of here. This is part of mediastinum. يعني كل واحد.
At the
عادي.
T3, T4 level.
T4. Okay, at T4. So was this clear? Do we move into cross sections?
Yes.
Tamam. Now, for cross sections, you guys need to be able to understand the orientation before you can actually start identifying the structures. So when you're looking at a CT scan cross sections, and you imagine you're looking at a person that's laying down and you're facing their feet. But your right is their left, meaning the right and left are going to be inverted. And at the very top is anterior, at the very bottom is posterior. And the very top is the front part of the patient, and the very bottom is the back of the patient. And again, you guys, for this, you're going to need to use your mediastinum knowledge. I know you covered it with Muhammad. And for the cross sections, which are CT scans, we're going to have 4 levels. There's 4 levels I mentioned at this point right here, this point here, here, and at the bottom here. So for each cross section, I found there was a diagram like this and the actual cross section. So the diagram here is just for your reference. You don't really need to know all of these labels. The only important labels are the ones in the actual CT. Okay? So can anyone tell me what level we're at? Are we at the superior mediastinum? Are we at the inferior mediastinum? And why?
We're at the superior.
Okay, why?
Because you have the 3 branches of the aortic arc, and also because you have the trachea.
صح? Amazing. Can you label the structures بالمرة? Would you know how to label them? Just the ones you know, if you don't know them.
One is left brachiocephalic vein. 2 is
Okay.
right brachiocephalic vein. 3 is left common carotid. Sorry, 3 is brachiocephalic trunk. 4 is left common carotid. 5 is left subclavian. 7 is trachea, and 6 is 6 is esophagus. Yeah.
Very good. No, we're definitely getting you guys a CT or a cross-section from the real pictures. Million for me, this is in every single exam. They bring to. Sorry, did someone say anything?
No, I want to ask what was 2, but then I saw something like that.
Here, this is the right side, and this is our left side. Here we have the trachea. We have these 3. These are coming from the arch of the aorta. And if you were to go back to this part, this is the arch of the aorta. But right next to it, we can see the 3 structures. We can see the brachiocephalic veins, and then the left one is the long one, the right one is the short one. Does that clear up the confusion? So you can see here, and it would be larger because the left is longer. All good?
Yes.
So this is the first level. So it's all just memorization, basically. The second level, does anyone want to label the structures?
Two is arc of aorta. 1 is inferior vena cava. 4 is, I think it's still the trachea, right?
Yeah, 4 is the trachea.
5 is the esophagus.
Okay.
And 3 is it the azygos?
3 is the azygos. But can you repeat what 1 is again?
1 is the superior vena cava.
Superior vena cava. Sorry. This is great. Does anyone have any problem with these? The main part that you're looking for is that you see the trachea, it tells you you're in the superior mediastinum. If you don't see the trachea and you see 2 bronchi, you're in the inferior mediastinum. And if you're at the superior mediastinum, you start looking for the arch of aorta, or you look for the brachiocephalic, carotid, and subclavian, like those 3 coming from the arch. Again, these specific features are going to tell you which level you're at. And then from then, you can just figure out the rest. So this is the third one. Do you guys want me to keep going over each section, or are they clear to you? Because they're mainly just recall.
No, it's clear.
Okay. So again, you guys genuinely need to know these. Like, we need to go over them. Just the labels for the CTs. Okay. Are all of these clear? Are any of them confusing? Tell me. And this is the fourth one. You guys said you're good with them. The labels are here as well. And then these are the CTs. And then we have the actual cross sections from the anatomy. Have you guys faced any kind of difficulties with these? I know that they can look intimidating, but again, just look for the main things. If we see the trachea, obviously it's not going to mention superior mediastinum here, but if we see the trachea, we know this is the superior mediastinum. And behind the trachea, always, we have the esophagus. We see these 3, for this is not the arch of the aorta, but just above it. If we're just above the arch of the aorta, it means that we can see the left and right brachiocephalic veins. And which one is the longer one? The vein. And the right is the shortest one. Yeah, this is how you identify them all. Same thing, it gets very repetitive. Any difficulties with these? Any questions? Anything not clear? And it's the same things as the CT, but just a different looking diagram. Same thing here as well. Can it be flipped in the exam? No, they're going to bring you exactly the same pictures. They don't change the pictures. They just print out the picture obviously without the labels. And they might then tell you what structure, number, whatever. And then ask you, they might ask you to identify more than one structure, but it's exactly the same picture. If you guys memorize these, like 3 marks. And this is another version they can ask you, and it's also the superior mediastinum. And the labels are here. And this is it for cross sections. Any questions? Any confusions?
No, it's clear.
Now for X-rays, I remember in our final last year, they got us this X-ray, and then they asked us which one is 4 or 5 or 6, and they asked us one of these bumps. So, صراحة, it's again memorization, but this is the normal X-ray. You have the trachea right here between the two bifurcations. You have the carina. This is the rib cage. This is the diaphragm. This is obviously the heart, and then you identify them by them. And it's just memorization. Just memorize them. 3 marks again. This is a sideways view. I don't think this is as important as the one before. I've seen it for questions before. Oh, but also keep in mind, it's inverted. So again, this is the left side. This is the right side. Most things are actually. This one. So I don't think they're gonna ask you much from this. It's not that important. This I included it anyways. Now for X-rays, there are some clinical ones. Now here we have the bronchogenic carcinoma. There was not much of an explanation in your lab manuals or the objectives about this, just the picture. I guess memorize it. For the pneumothorax here, we have a collapsed lung. And when the lung collapsed, air entered the pleural cavity. And the air, it's going to appear black in X-ray. But this tells you that this is pneumothorax. There's air in the pleural cavity. Here, it's hemothorax, where it tells you there's blood in the pleural cavity. And it's not black like here. Here, it was just air. But here it's fluid and it's blood. So this is hemothorax, and this is the collapsed lung. This is the collapsed lung. This is clear?
Yes.
Then, Horner syndrome, guys, they got us this as an SAQ. Like they brought us the X-ray of Horner syndrome, and it was a bunch of questions about the syndrome itself. It was just from the X-ray, and you have to identify it from the X-ray. So remember the clinical X-rays. You can see that there's a right side lesion here. And this one is a CT showing you a left side lesion. Okay. And it's an apical cancer of the lung. It's also called the Pancoast syndrome, and it results in the compression of the sympathetic trunk. And because the sympathetic trunk is going to be compressed, it results in the 3 clinical presentations: ptosis, meiosis, and anhidrosis. Ptosis is the drooping of the upper lid. Meiosis is constriction of the pupil, and anhidrosis is the loss of sweating from one side of the face, the side that's affected. Memorizing histo. Anatomy is clear. Do you guys want me to go over anything from anatomy? Any part?
No, it's all clear.
All clear? So, do you guys need any break, or should we keep going?
We can keep going.
We'll keep going. Yeah. So histo is divided into the upper respiratory and the lower respiratory. Upper respiratory, we have the nasal cavity and we have the trachea. Lower respiratory, we have the bronchi, the bronchioles, and the alveoli. Now for pulmohisto, it's very, very easy, guys. Like, I love pulmohisto. I find it really, really cute. Remember this picture earlier from the nasal cavity? We're looking at the same thing, but in histo form. It just looks more deformed because this is taken from a mouse, not a real person. And this region is going to be divided into 2 parts. Like we mentioned earlier, there's the olfactory region and there's the respiratory region. This part here, this top part, is the olfactory region, and the respiratory region is this part right here. These are the concha coming from the lateral wall, and this is the septum dividing it. It's having the same thing as this, but in microscope picture. Okay, so let's start with the olfactory region. Look at this diagram here. This top part we said is the olfactory region. If we were to zoom in like crazy, this is what it looks like. And this is the upper third of the nasal cavity. And the main function of it is just to detect smells. It detects smells, that's it. And the epithelium found here is the pseudostratified columnar epithelium, but without goblet cells. Most respiratory epithelium has the goblet cells, but this part is an exception. It does not have the goblet cells. But if they were to bring you this, also the main focus of histo, usually in OSPE, is that they would bring you a picture. They would ask you, identify the epithelium, identify the function. So the main parts are for you to know the epithelium, know the function, and know the slide. This is olfactory region. And this is the concha again, and the protrusions from the lateral wall we mentioned earlier. And this is the epithelium. You can see the SC, which are the supporting cells. They're basically there for mechanical and metabolic support. Basal cells, which are the stem cells. There's not much to it. I don't think these are that important for OSPE, But epithelium function, very important. Okay. The respiratory region, which is the lower 2/3 of the nasal cavity. It's the majority of the nasal cavity. The main function of it is to warm, humidify, and clean the air. Again, we see the concha, the lamina propria, and then we have the respiratory epithelium. But again, most important part, epithelium function. So let's zoom in further. You can see the epithelium here. It's pseudostratified columnar and ciliated, and it has goblet cells. Olfactory region did not have goblet cells. This has goblet cells. And we can see the cilia here. We can see the goblet cells. The goblet cells are going to be secreting mucus. We can see the basal cells. We can see some blood vessels. Well, yeah. This is clear? This is the nasal cavity.
Yes.
And now we'll move on to the trachea. So this is the trachea. We said that it has the C-shaped cartilage, the back no cartilage because it's next to the esophagus. If we were to take a section from the C-shaped cartilage, we would see this. It has different layers. It has the mucosa here. This part is the one that's facing the lumen. The air is in this part. And air is facing the respiratory epithelium, which is part of the mucosa. We have the submucosa. We have the hyaline cartilage, which is basically the C-shaped cartilage, and we have the adventitia. Now, the mucosa has the respiratory epithelium. Can someone tell me what respiratory epithelium is? I mentioned it earlier.
Pseudostratified columnar with goblet cells.
So, and don't forget ciliated.
Yeah, cilia.
Perfect. Respiratory epithelium is gonna keep going with this for a long way if I remember it. And it has the lamina propria, kind of, not relevant. You don't really need to know these different parts, just know the hyaline cartilage. Adventitia is basically connective tissue and it binds the trachea to the nearby structures, not that important. This is another picture showing you a close-up of the respiratory epithelium. You can see the cilia well, you can see the goblet cells, and you can see here the basement membrane, you can see the basal cells, and it's just closer. And the function of the mucosa, we said for protection, secretion, and for immunity. And when we go further down, first of all, we started with the trachea. And then we went down, the trachea splits into the main bronchi, and it splits further, and then we have bronchus, or the bronchi, and then we'll have bronchioles, and from the bronchioles, we'll have alveoli. But now let's take a look at the bronchus. Now, comparing this with the trachea, we'll see two main changes. We no longer have the C-shaped cartilage. Instead, we're going to have the hyaline cartilage in plates. It's basically irregular pieces of cartilage. It's not a complete C-shaped cartilage. It's just random pieces of cartilage found around. You can see here there's like a random part. Here there is no part. So this is one of the main changes. Also, there's going to be smooth muscle, and it's going to complete a layer. We have smooth muscle here. So again, the mucosa, it would be respiratory epithelium, which, as we said, is pseudostratified columnar epithelium with goblet cells and ciliated. I forgot that part. So this is a bronchus. That's it. This is as we keep going down, it's going to decrease in size, but it's still an intrapulmonary bronchus. It's not a bronchiole yet. We'll see the comparison in a minute, but it's still considered to be a bronchus. There's a bunch of details here, and you can read them later on. Just know that the epithelium is again going to be the respiratory epithelium. We'll have the random pieces of the cartilage. It's not going to be complete pieces. And yeah. Now, as we go down, it becomes a bronchiole. Now, the bronchiole does not have cartilage. This is the main distinction between the two. So, they're going to show you something like this, or maybe, hold up, like this. And they're kind of, they look the same. If you just look at it quickly, they look the same. So when you take a closer look, you realize that here there is no cartilage. This tells you that khalas, we're no longer at a bronchus, but we're now at a bronchiole. Bronchiole has no cartilage. The mucosa, again, is going to be the respiratory epithelium. So it's ciliated, pseudostratified, and it has a few goblet cells if it's a larger bronchiole. Now when the bronchiole, because now it's splitting further, it's going to be a large bronchiole, and it's going to become a small bronchiole later on. Large bronchiole has respiratory epithelium, but the smaller bronchioles are not going to have respiratory epithelium anymore. Instead, we're going to have simple ciliated columnar or cuboidal. Now, why is the epithelium changing? Because in our lung, it's the main function. The main function is gas exchange. And gas exchange can't happen through a very thick layer of epithelium. It has to be a very thin layer of simple squamous. So it's going to gradually thin out until it reaches the alveoli, where it's going to be a very, very thin layer. So here, we're getting closer to the alveoli. It's going to become thinner. We're no longer seeing cartilage. And yeah. here, the epithelium is going to be either pseudostratified for the larger ones, or it's going to be simple ciliated columnar or cuboidal for the smaller ones. This is the comparison. Here you can see the cartilage, the random pieces. Here you don't see the random pieces of cartilage. Here the epithelium is going to be thicker because it's pseudostratified, and here it's just على حسب which point we're at. And this is the comparison. And finally, the respiratory epithelium. Well, sorry, the respiratory bronchioles. The respiratory bronchioles are going to be branching into several alveolar ducts. Alveolar ducts are going to give us the alveoli, but this is respiratory bronchiole, and it's going to be giving us the random alveoli. Here we see smooth muscles, and we see elastic fibers, and you can see the alveoli. Now, the main part, the most important part of this is actually in the next slide. Here it's going to be simple cuboidal epithelium with cilia, and it has club cells. Just refer to your maybe manuals for what the club cells are. I think I mentioned them earlier. Now, for the alveoli, we have alveolar ducts, and then they're going to become alveolar sacs. The alveolar ducts are going to become sacs. And there's no walls. The alveoli are peripheral boundaries. And where's the most important part? Yeah, this is the most important part. The alveolar cells. This is where they're probably going to ask you a question about the alveolar. We have two types of alveolar cells. We have type 1 pneumocytes and type 2 pneumocytes. Type 1 are very, very thin, just like here. This very thin layer. Very thin, very thin. The main purpose is for gas exchange, and it's forming the blood-air barrier. Main purpose, gas exchange. Type 2 pneumocytes are kind of, they appear to be, they're protruding out, they're kind of larger in size, they're not as many as type 1, and they're going to be dispersed cuboidal cells, and they're progenitor cells, and they're for type 1 and type 2, and they also secrete surfactant. So your main part to know about this is that it's going to secrete surfactant. Type 1 is for gas exchange, type 2 secreting surfactant. And we also have alveolar macrophages, which are going to remove inhaled particles or RBCs or whatever. These are kind of difficult to spot because I don't think they're going to ask you for them. Unless there's a very specific picture they had. I did not see one, to be honest, but just make sure to double check for the point. Come on. And for the visceral pleura, now do you guys remember when we talked about the pleura, we talked about how there is the visceral pleura and we have the parietal pleura. The visceral pleura, we said that it's the part that's going to be stuck to the lung. And so when we're looking at epithelium slides, we're going to see the visceral pleura. It has simple squamous mesothelium. You can see it here. It has the very, very thin cells, and it's going to produce a thin amount of surfactant. Of serous fluid. And this serous fluid is going to be acted as a lubricant, and it just really facilitates the movement. Okay. And it also has thin connective tissue layer, and it's going to contain collagen, and it contains elastic fibers. Most important part is type of epithelium. Okay, question. Who wants to answer?
So this is the bronchus, bronchiole, I mean, bronchiole.
Yeah.
And the identification points is that it does not have any cartilage.
Mm-hmm.
And it has thin muscularis.
Yeah, I think that would be accepted. Let me see. It has a thick smooth muscle there. It's thin. Okay, I've been awake for a long time. I'm so sorry. Yeah, so it lacks hyaline cartilage, like you mentioned, and it has a thick smooth muscle layer.
Can we say no submucosa?
Yeah, no submucosa works.
Okay.
So bronchiole has a thicker smooth muscle than bronchus.
Yes.
Yeah, okay.
Another question. Can you identify what's labeled as X and name its function?
Yes.
Someone think?
It's pneumocyte type 2, right?
Yeah, pneumocyte type 2. Oh no! So can you tell me the function? Pretend like you didn't see that.
It produces surfactant and it acts as a progenitor cell.
That was amazing. Last part, guys, physiology. Physiology of the lung is very, very, very simple. They usually only bring the same 2 questions, and they've been recycled every time. One of them, and they're both here. Like, inshallah, you'd be fine. First of all, let's just, familiarize yourself. Let's talk about the important definitions. Now we have tidal volume, which is the normal breathing volume. We have the inspiratory reserve volume, which is the maximum inhalation. If I inhaled maximally, this is the volume that's filling my lungs. We have expiratory reserve volume, same thing, but for exhalation. So maximum exhalation, it's like the maximum amount of air that I can exhale forcefully. And we have the residual volume, which is the amount of the volume that's just it remains in your lung and you can't exhale it. Next, we have inspiratory capacity. We have this, which is basically the tidal volume with the inspiratory reserve volume. But it's the maximum inhaled. We have the functional residual capacity, which is the residual volume with the expiratory reserve volume. We have the vital capacity, which is everything excluding the residual volume. So it's basically everything that you can exhale, everything you can inhale, rather residual volume because it doesn't leave your lung. Very brief overview. You guys already took us in physio lectures. Now, to assess the pulmonary function, why are we doing this to begin with? We want to see if a patient maybe has restrictive disease or an obstructive disease, or if they don't have a disease. And how do we do this? We use a spirometer. So we ask the patient to exhale using the mouthpiece. They use the mouthpiece, they plug their nose, and they exhale maximally. And this is the kind of curve that's going to be generated when they exhale maximally. We are going to get 2 values. We're going to get FEV1 and FVC. We're going to get FEV1 and FVC, and these are the normal values. Usually we take these values, we divide them, and we get a ratio. So if the patient is normal, their value would be 0.8 or around that. So just explaining it, yeah. But we're seeing if we have restrictive disease, you have obstructive or what. So let's see how the curve would look like if they were to have a restrictive disease. First, can someone tell me what the difference is between restrictive and obstructive? So the difference is restrictive is that the patient is struggling with inhalation, whereas obstructive, the patient struggles with exhalation. So restrictive, if the problem is with inhalation, not exhalation, so the curve looks normal, because also this curve is assessing exhalation. The curve looks normal, but it's just lower, because the patient also to begin with hasn't been able to inspire the amount of air that normal patients do. It's a normal looking curve, but it's just lower. We're going to see a decrease in both FEV1. By the way, FEV1 is taken for the first second, and FVC is the maximum exhalation. So we're going to take the 2 values. We'll see that there's a decrease in both of them, but it's a uniform decrease. And both of them have decreased equally. So when we're dividing it to get the ratio is going to be very similar to a normal patient. So there's decrease in FEV1, decrease in FVC, but the ratio is normal. And the curve is going to look the same as the normal, just a lower volume. For obstructive, the problem is with exhalation, and the test is already testing exhalation. When the patient's asked to exhale, their FEV1 is going to be decreased significantly because they can't exhale, and also we're measuring it for 1 second. But it's going to be a very crazy decrease. You can see here, and it's a lot of it, a very significant decrease. Their FVC is also going to be decreased. This FEV1 is the one that's affected the most. So the ratio is going to be decreased because also we're dividing these 2. The ratio is going to be decreased. So in obstructive, the ratio decreases. In restrictive, the ratio is approximately the same as normal. Okay, it's just explaining it. Tamam. And this is another curve that we can bring you. Okay, this is a different appearance of the curve. The normal one, you'd ask the patient to inhale, and then they'd exhale. And then they'd reach the peak expiratory flow, and then we'd see the normal exhalation. Okay, this is the normal curve. If they have an obstructive disease, it means that they have a problem with their exhalation. You're going to see the coving, this one. You're going to see coving. And this is due to the airflow being limited. They can't exhale properly. There's a problem here with exhalation. For restrictive, their exhalation is normal. It's just that the air amount is less to begin with. So it looks the same as the normal one. It's just small. Okay? The volume is less. Okay, so they're either going to use it looks like this or something that looks like this. And this is a question. This question has been repeated in so many exams. So can someone tell me which one shows obstruction? Let me see.
B.
B. And حتى 2 people mentioned B in the chat, and that is correct. So which one would be restrictive? Which one is normal? Like, tell me more. Okay, C is restrictive, صح, and A is normal, correct. So they look the same, it's just that there's a decrease. So yeah, and I think this is it. This is it with the PAL. Have you guys had any problems? Anything you want me to repeat explaining? Anything? Is it all clear?
For the volume time curve, the volume refers to the expiratory volume, right? Not like how much
Yes.
volume was there in
Volume
the decrease.
exhale. Yes.
Okay,
Yes.
thank you.
No problem. Now, tomorrow's your first, not tomorrow. I'm joking, not tomorrow, but like in general, this OSPE is going to be your first in real life OSPE. Do you guys have any questions about it in general? Do you know how the flow is? Do you understand how the OSPE works? Or do you have any questions about that?
Is it like
I think
possible
we're
to
all
go
good.
back to a station
You can't go back to
in
a
the OSPE
station.
or no?
How the OSPE works is that they're going to give you a clipboard and a paper. And this paper is where you're going to be filling out your answer. Each person starts at a different station. It's just like the mock OSPEs you guys have been doing at Paul. You can't go back to a different station, but if you finish a station early, you can fill the question later on yourself. And مثلا, let's say I struggled in question 2 and I already moved on. خلاص. I can't go back to question 2. But maybe question 5 was really easy, so I finished it quickly. In that time, I can solve question 2. And there's also 2 rest stations, and in that time you can just sit and go over your answers. So what I normally do is that if I have a question and I know like okay أنا شوي جبت العيد in this question, I write down what the question was in the margin, so that in the rest station or if I'm free later on, I can just go over it.
Okay,
During
thank
rest
you.
stations, can I go back to the stations? You can't go back to the previous stations, but you can answer in your own form. The paper, they're not going to be like, why are you answering a different question? They can't even see what you're doing. But in the rest station, when you're sitting, you can answer whatever you want. Anything else? Thank you guys so much for attending. I know it's 10 and haram, you guys are probably like, خلاص, you want to sleep or maybe study other things. Just thank you so much for staying along, and I hope you have a great day or a great night. If you have any questions, my number is at the beginning of the PAL. Feel free to contact me.